Welcome to all for this international webinar, most awaited since long time. It's a great privilege and honor to have our National President, Dr. Rajan Sharma, Dr. Ashokan Sir, Secretary General. Next, Dr. Ravi Wankhedkar, who is a past president, national past president of, and also World Medical Association treasurer. Next, I welcome Dr. Avinash Bhondwe, Maharashtra State President, Dr. Shara Jaitley, who are joined from US and enlighten us on COVID topics. Dr. Inder Mohan Sharma, Narula sir, is from Japan basically, but now has settled and serving for the Mongolian government. Dr. Peter Patel from UK, Dr. Sanket Barale from DigiShield, he's also joining. And I welcome all the distinguished guests from all parts of our country. They are from all the states. So welcome all the president and secretaries pan-India. Secondly, I welcome all the honorable delegates from all parts of our country. It is indeed a pleasure that we are together for this historical event. I would say Pune being a historical city, it's a historical moment that we all are fighting for COVID, and for this we have chosen this topic from all of, I would say, one of the best stalwart faculties. I welcome all the stalwarts from, I would say, all part. Thank you. And I request our president, Dr. Arti Nimkar madam, to say a few words and give our presidential address and welcome all of the guests of honor and chief guest. Thank you.
Yeah, thank you, Rajan, for starting the webinar. I welcome you all, the international speakers, Dr. Shara Jaitley, Dr. Narula, and Dr. Peter Patel, and our stalwarts from the IMA, Dr. Rajan Sharma, our national president, Dr. R.V. Ashokan, our secretary general, Dr. Ravi Wankhedkar, our past president of the national IMA, and Dr. Avinash Bhondwe, now the present president of the Maharashtra state. And it is a very great pleasure to have this international conference in IMA Pune. And we were trying for long and adjusting the timings and dates and all these things. And now today we are here to have this seminar, this webinar. So we all doctors are fighting against this pandemic, which is not expected, not predicted, and very much painful situation is there. We have lost most of the physicians who are working against the corona infection and treating the patients in the hospitals, in the ICUs, and most morbid patients we lost in our nation all over the world. And whole world is finding the proper treatment and proper progression of the health, how to introduce the vaccine, but we are not yet very much successful. And to all discuss this, all these stalwarts are here, and they will guide us through the situation and how to behave after the infection also. We are getting less patients now, but still it is not over. Fight is again, I think, waiting after second surge we will not have in India, like US and other countries. So let us see what we can get in our this knowledge and share the thinking of these people, speakers. So we will start with our guest of honor, Dr. Rajan Sharma. that we are very much, we have the very much pleasure to welcome our National President as a guest of honor for this webinar. It is my pleasure to introduce him. In a short way, I'm trying to get the introduction to you. Uh, he has been a proud alumnus of the Dayanand Medical College and Hospital, Ludhiana, from where he has done his MBBS and MS in orthopedic. He is a renowned orthopedic surgeon from the Yamuna Nagar, Haryana. He runs 30-bedded hospital, Rajan Hospital, and also Dr. J.P. Sharma Memorial College of the Nursing in the Yamuna Nagar. His baptism is in the IMA started in his early age when his father led Dr. J.P. Sharma led the local IMA in Haryana state in 1977-78 and later had the organized Medicon 1989 in Yamunanagar. His father was also vice president of the IMA headquarters. Dr. Rajan Sharma is a member of the IMA since 1999 and since then he has served the association as a president of the IMA Jaddari Yamuna Nagar branch in 2006-2007, president of the Haryana state branch from 2011 March to 2013. During this tenure as a president, he was able to revive the state IMA and help in the achieve new heights. He was a member of the IMA CWC for many years and he was director of the IMA Ken Sinha Institute of the Medical Sciences. He was a member of the IMA HBI in 2016 and now he is the national president since 2019-20 year. Since 1999 onward, he started taking the proactive initiatives in the working of the IMA Haryana state branch. He is involved in the many social activities and apart from the medical practice, and Beti Bachao program of the national zone is one of them. Haryana is the only state where the exemption from the Clinical Establishment Act has been granted to hospitals less than 50 beds. Haryana is one of the few states where the District Medical Negligence Board has been constituted, thus ending the terror of the police complaint and the arrest in the negligence cases. Haryana was the third state where the Act for the Violence Against the Doctors came into the existence. These achievements have come with the ongoing efforts of the successive team, but the foundation were laid during the tenure of the state presidency. To maintain the honor, dignity, and to uphold the interests of the medical profession and to promote the cooperation among the member and fight against the doctors' unfriendly politics of the administration are amongst his priorities. His other credentials in his name are the 7 international publications, Paul Harris Rotarian and Rotary Medical Mission Director to Rwanda, Gabon, Zimbabwe, etc. The true leader is always practices the 3 R, the respect for the self, respect for the others, and responsibility for all their actions. And one more R is in your name, sir, Dr. Rajan Sharma, sir. Welcome, and we are eagerly waiting for your guidance to our delegates and doctors. So I request you to say a few words about the situation.
Thank you, Madam President, and the State Branch Secretary of Pune, and the entire Pune IMA and all the dignitaries who have joined in. Thank you so much for the adulation.
Thank you, sir.
But I am one amongst you. Whatever good or bad I could do, I tried to do that. the profession today, the challenges it is facing, we have to rise up as individuals. And when you rise up as individuals, the first thing you do is to put your house in order. As I demit office, we have to put our house in order. And onus does not end at the national president or HSD. It starts from every individual member of every branch. COVID, when it started, I perhaps might be the only president who has not traveled to for any meetings. But I proudly say, to hold the fort, I traveled frequently to Delhi every week, despite my family reservations. Because you have to build up the confidence in your staff and take the battle ahead. I'm also proud to say, as ably assisted by my HSG Dr. Shokan sir and guided by Dr. Ketan Desai, we could take up many issues ably and from the front. And the national president is a team leader. I have got very valuable inputs from even Pune IMA, Avinash Mondwe, all the state president secretaries. Suddenly we were found that our pent-up frustrations had to come up. And this was the occasion where the entire nation, I feel happy as a president, when the entire nation expresses gratitude at what we have done. At the end of the day, take it or leave it, now we take our insults with a pinch of salt. But we are a wonderful human beings. If you, ma'am, or anybody of my members who are watching this, see a patient in distress, we will forget every consequence which might happen and do our needful. I am a second generation IMA person. We didn't have our holidays because my father was so dedicated to the profession. And this is the sacrifice which all of our children undergo. Society might not acknowledge. If my child is sick, even then I'll go down to see the emergency, not for the greed of money. It's wrong. I always say, we have done so much. We have slept on stretchers, we have slept on floors, we have slept on empty hospital beds. That this extreme sacrifice can never be acknowledged and thanked. As I'm sharing with you today, there's a very disturbing news that medical students are being made to pay a stupendous amount of money for pursuing some medical education. It has come in Haryana. It is there in many states, UP and everywhere. Haryana came out with a scheme that we will be giving you loan, but there is a no job, promise for job. Today, it is very easy to blame the doctor. There are doctors don't go to the villages. But tell me one thing, where the jobs and facilities are there? As I am talking to you, contractual job, 3 months, 4 months is a ground reality. Is it our fault? And I can quote innumerable instances in the country where my colleagues have not been paid salaries and those who have retired. The Bada Hindu Rao issue, where he filed a contempt proceeding against the Delhi government officials and the MCDs. After 2 years, they are not even getting their pensions. As is evident, we are warriors. Soldiers don't bring their bullets home. We bring our disease home. Whether it is COVID, whether it is diabetes, whether it is hypertension, whether it is tuberculosis. Time has come. We have to rise up to the occasion. And especially there has been a sea change in image of doctors and IMA, and we have to live up to that. As we battle corruption of modern medicine by khichdi doctors and other things, I am not against any, we at IMA are not against any cross-pathy, Ayurveda or anything. Let them pursue their independent agenda. But if these systems are so good, why do you want to make it into a modern medicine? Ma'am, through you, Pune and an important state like Maharashtra, we have to rise to the occasion and be a sheet anchor to our medical students who are so perturbed by this unprecedented hike in medical education under the garb of loans and the recent NMC regulations, dilution of medical colleges. As I am talking of Pune, I have very fond memories of BJ Medical College, AFMC Pune, where I had come to play a cricket match. Such huge campuses. And now you want to corrupt the entire system by just having 3 institutions and doing away with land norms. When you become a doctor, you become an individual and you evolve with the system. All of us have very fond memories of our illustrious teachers. So with these words, I wish Pune IMA a very grand success for their international meeting. Thank you so much. I think I have taken a lot of time.
No, sir.
Thank you so much.
Very much, sir. May I request Dr. Ati Nimkar, President, Madam, to introduce also Dr. R.V. Asukan. And after this, we will have an inauguration and then we will start our webinar. Madam, please introduce Dr. R.V. Asukan, sir, and let him address a few words.
Our Dr. R.V. Ashokan sir is the Secretary General of the National IMA, and he is a practicing general physician running a 26-bedded hospital along with his wife, Dr. Laila Ashokan, a gynecologist in the Kunnalar of the small town in Kollam district of the Kerala state. He was the IMA State Secretary of the Kerala for 3 years and later its state president. He conceived and established IMAGE, the biomedical waste project of the IMA Kerala state branch in 26 acres of the land in Palakkad. Biomedical waste of the entire Kerala state is being handled on daily basis by the IMAGE. And including COVID waste, he served as IMA National Coordinator for the TB for Private-Public Partnership and also in Strategy Technical Advisory Group of the WHO Geneva. He was the National Secretary of the IMA Hospital Board of India for 4 years and its chairman for 4 years. He was the chairman of the Action Committee, which shaped the struggle against the NMC. He is currently the Honorary Secretary General of the IMA Pune. Welcome, sir. And we...
May I request, Madam, that we will start the inauguration ceremony. Dr. Rajan Shankaran, sir, Dr. Ashokan, sir, please, we are starting with the inauguration. With your kind permission, Please say, sir, that inauguration has been done.
Inauguration done. I am
Thank you, sir.
Rajan Sharma, not Shankaran.
Rajan Sharma, sir. Thank you, sir. May I request Dr. Asukan, sir, to say a few words?
Yeah. Kindly allow me to be brief because I think the National President has briefed you on a host of issues. Let me congratulate the Pune branch for this wonderful initiative. At Pune, you have the burden of legacy and history. The branch started in 1928. I think equivalent to the Indian Medical Association itself. I have been there for in the building for many times for the work in TB hospital board, and also I have enjoyed the hospitality of Pune branch many times, and it's a matter of record and satisfaction that up to 2005, even the Maharashtra state branch functioned from Pune IMA. So a branch which has held a lot of responsibilities, taking up a responsibility of spreading up the word for COVID to the general practitioners and our members. I congratulate that effort. We have, from the day one of the pandemic, we have learned much and we have unlearned much. For example, today we know that the virus doesn't replicate beyond day 9. And the most infective period is from 0 to 4. And this has resulted, very unfortunately, in martyrdom of a lot of doctors in India. 627 doctors have died as of 30th of October. And 2/3 of them are general practitioners because they see the patient when they don't come with a label of COVID. And they see in chambers which are very small, and they give quality time to the patient. They practice clinical medicine, touch the patient. So, but fortunately for the past 1 week, this has been declining. Indian Medical Association has announced a martyr fund, IMA martyr fund, for the IMA members, doctors who sacrificed their life for the country. We in IMA headquarters appeal to the entire medical fraternity to contribute to this fund to sustain and support the members, family members of these martyrs. With that, I congratulate the Pune branch, your president, Dr. Rajan Jaitley, the faculty. You have such an eminent faculty, including your state president, Dr. Avinash, Dr. Ravi Vanketkar, past national president, Dr. Shara Jaitley. I congratulate you, and special congratulations on spreading this, disseminating this information throughout the country and making it accessible to all our members. Thank you so much.
Thank you very much, sir, for an excellent. In brief, you told a lot of things to us. Thanks a lot, sir. Next, may I request Dr. Meenakshi Deshpande to introduce our next speaker, Dr. Avinash Bhondwe, our state president, a dynamic leader. Please, Dr. Meenakshi, I will start the introduction. And I don't think we have to introduce because sir is a dynamic leader. Still, I would like to introduce him. He's MBBS from Pune University, Vijay Medical College, FCGP 216, he has done it. He's a practicing family physician since 1984, practicing in Shivaji Nagar area and very well known among the public there. He's a panel consultant for many hospitals, Dinanath Mangeshkar, Pune Hospital, Sahyadri Hospital, Ratna Memorial, Surya Hospital, Sanjeevan Hospital. Sir has taken a lot of positions. He's a president for Maharashtra State, 1920, Senior Vice President, IMA, past President, IMA in 2016, Honorary Secretary IMA CGP, Joint Secretary IMA CGP in Maharashtra State, 2013-14, member since 1991, and we know he has taken a lot of fight to, I would say, in administrative, and had a lot of, I would say, publications. He's a very good writer also, very good orator also. So I request Dr. Avinash Bondwe to start his lecture. Please, sir.
Yeah. Thank you, Dr. Rajan, for very kind and brief introduction. Our today's honorable guest, Dr. Rajan Sharma, the president of IMA, the Dr. R.V. Asokan, our honorary secretary general, of course, Dr. Ravi Wankhedkar, our leader and a good friend, and all the international speakers, Dr. Shara Jaitley, Dr. Peter Patel, Dr. Indramohan Narula, and our own IMA Pune branch, Dr. Arti Nimkar, Dr. Sanjay Patil, Dr. Padma Iyer, and of course, Dr. Sancheti, and all other friends. As you all know, the topic which is given to me is early policy actions and emergency response to COVID, to which I have rather termed as the tears of the frontline warriors, that is doctors. Dear friends, as most of us in school days must have known that the river Brahmaputra was called as tears of Assam. Every year, the thousands and thousands of people were rather, there were floods and thousands of people used to die, used to get affected with that floods. There is one phenomenon known as in China as blue tears. It is actually caused by a bloom of tiny bioluminescent creatures, which are called as dinoflagellates. The tourists from all over China come to view the twinkling skyscape. This twinkling seascape, the bloom in the East China Sea looks very beautiful, but it is very toxic, and it is going bigger every year. Dear friends, on 31st of December 2019, a frantic message was sent to WHO describing the hundreds of cases of pneumonia caused by some unknown virus. And from that day onwards, when the new year began, it spreaded the tears to all over the world, and that is the COVID-19. The main affected people were all the doctors. As you all know, it soon spread to Korea, Japan, then Europe, America, and many Asian countries like UAE and Iran. What was the first response of India? Ideally, if we say there was no response from the government side initially in the month of January. In the early January, there was no response. We started giving response from the 17th of January. But the way, actually, as doctors, what we feel that the government should have done something to educate our doctors, government doctors as well as private doctors. Nothing was done. The health workers should have been taught some principles. Nothing was done. The government officials not trained. The policemen and others who were all also called as frontliners. Absolutely no information till then. And public awareness, nothing. Indian Medical Association began its public awareness campaigns in the midst of January. By that time, even people were not knowing what was COVID, what was Corona. What the government did as early response was they closed the schools from 13th of March, first till only for till 30th of March, and then extended indefinitely. All the exams were postponed. Since the schools and children were supposed to be affected because of closeness, because of the social distancing cannot be observed there. All the cinema halls, all the social gatherings were called off. and all the uh, uh, industries were asked to do to conduct their offices, that they were advised to work from home. A one-day curfew on 22nd of March, and then the national lockdown from the 25th of March. That was the day which was called as Gudi Padwa, the first day of Hindu year, 25th March. We began with the lockdown, which ended till 31st of May. First lockdown, second lockdown, third lockdown, all these things were rather called for by the government of India. Then the phase of unlock began from the 1st of June. And then all those people who were staying without food, without shelters, went to their own places. All these migrant workers, they went to their cities, and they, along with this infection, was spreaded all over India. Then the travel was also rather controlled. Initially, the international air passengers from China, Korea, Japan were rather uh, traced for the virus. They were, but that time only the temperature with the thermal scan was taken, and only those people, as per the knowledge at that time, only the people who are having fever were rather asked to check for their COVID test. But after that, this was rather extended for 7 countries. And from the 22nd of March, all the international travels were closed down. That time in India, the things were this COVID was an imported infection, and everything was seen like that. The trains, buses, locals, and metros all stopped from the 15th of March onwards. What the government did was they revived the Epidemic Act 1897 and revival of Disaster Management Act 2005. And all the powers were given to the administrators. And that was the problem. The campaign of Corona control, campaign of COVID-19 control in India was handled mainly by the administrators, not by the doctors. The doctors, led by the Department of Health of Union government and ICMR, had some suggestions, and they were just blindly followed by all the administrators. We had rather the health infrastructure of India was really in bad shape when this pandemic struck India. The hospitals were very less. Government started to increase the hospitals. Then all the private hospitals were taken. Then the jumbo hospitals were created as a makeshift arrangement. The doctors were less. The government has neglected the health sector till now. And the doctors were less because there are less medical colleges in India, and the number of doctors are also not as per the norms by WHO. Of course, along with the doctors, the nurses are also less. All these things were rather hurriedly thrown on the private doctors, and private doctors started working with the government. They were called for COVID duties to attend the COVID hospitals. And after that, even they had to, rather their own hospitals were taken by the government, especially in Maharashtra state, by the government. And all these doctors were working to help to serve all these COVID patients. Same about nurses. Initially, the diagnostic labs were also scarce. There were only very few diagnostics labs. Right now, then government started expanding it. And in last 7 months, we have around 1,141 government labs all over the India, and around 2,069 private labs which are attached to the government work. The things that most of the resources were also very, there were very improper distribution, especially those very important things like PPE kits were very much in scarcity. The government doctors initially never had this. They were using very makeshift this thing. Sometimes somewhere at some places even the raincoats were used. The plastic raincoats were used as a PPE kits. It was rather mismanagement because all those manufacturers who were rather manufacturing the PPE kits were not given time properly, rather ordered properly to prepare for this, because we never expected, our government never expected that the pandemic will grow to such a large extent. And about the private doctors, till now, we do not get the proper PPE kits which are authorized by the government, which are rather done in a proper standardized way, and the cost we are not getting properly. The government now, after that, is getting enormous amount of these PPE kits at very reasonable cost, but private doctors are still not getting it. The same thing about the N95 masks. Whatever we get, we are using it. And same about the diagnostic kits. The diagnostic kits were not rather in proper number initially. After a few months, that the diagnostic kits, the Indian manufacturer were called for, and they are now preparing all these RT-PCR diagnostic kits, which are now in good number. Then the same thing happened about the oxygen. The infection is mostly a respiratory disease, and the people require oxygen by nasal mask, even in ICU, and of course with the ventilator. But the production of oxygen was not planned properly. In the month of August and September, there were rather large number of pet cases in Maharashtra as well as in India, and the doctors were running after the oxygen. Uh, there were black markets was being done. Indian Medical Association followed this. Rather, we asked the government to reduce the charges of the oxygen, but it was not done. And now, after a few days, after a few months now, at present, we are having good number of oxygen as per amount quantity is concerned, but not the rate. Still, the rates are not same everywhere. The government of India, initially, the rate per deciliter was per cubic meter was around 17 rupees 29 paisa, which was increased by the government to the 25 rupees, which was quite against rather our expectation. The medicines were very scarce. The government, rather, it was announced on the this media that such and such drug is effective. People used to jump on it and were using it, rather purchasing it blindly. The same thing happened about the HCQ. The same thing happened about the steroids and all the other things. All these things were blindly handled by the government. The doctors, for those to treat the patients, there were not sufficient quantity of all the medicines available. The same thing happened about the remdesivir, when the people, every patient who was in rather needing it, at least 6 injections per day per patient, but they were available only at the 50% stock was available, and the charges were asked by the distributors was very high. There were many cases of black marketing, and even after the control, the government did some these rules and regulations stricter, but nothing was done. Ultimately, when the production was increased and the rates were still made down, right now the medicines are available in at many places. The most of the problem about the oxygen and medicines was quite visible in rural areas. In cities, that somehow the people were getting, the doctors were getting the medicines, the hospitals were having some good stock. Sometimes they used to get the supply from the regular distributors around. But for the rural region, which represents the larger part of India, the larger part of Maharashtra, most of the time, even now, they're not getting these things in proper quantity. The very important thing which we doctors suffered was the inconsistent guidelines for the doctors. About the prevention. The prevention was also not properly advised. The diagnosis of RT-PCR, the rules were changing every now and then. Especially the most important thing was the antigen kits, which were ordered first, which came from China, were sent back. Then the antigen kits were used. But the things that they have the higher number of false negativity rate was not informed to uh, to the workers of the government sector. And that's why many of the patients, even many of the patients who are after getting this antigen test negative, they were not rather again followed by the RT-PCR test. Many patients rather were remain infected and undiagnosed. The same about the medicines. Many of the medicines first they were announced that they are useful, but one by one they were rather declared that they were taken out of the standard care. Especially the things about the ivermectin, then interferon, then even about the HCQ, then even nowadays the few days back the plasma therapy was also rather de-recognized, is not useful. Then again the remdesivir is also under big question mark at present. So all these inconsistent guidelines were rather the doctors were rather suffering from all these things. The main important thing, even the doctors were following all the thing coming across, and what they are finding useful, they're using it. But at the same time, the government was rather restricting even the rate of the oxygen to be given to a patient in ICU and ventilator was restricted, which was really fantastically. It was reduced at 7 liters for a patient only with on oxygen, and about 10 or 12 liters per minute for a patient in ICU. So we rather had a very big debate with the government that a treating physician should give, rather should be given that freedom, and his clinical acumen will be rather the main important thing, how much, which medicines to be used and which way, and about the oxygen, how much he should use. So all these things were debated and ultimately we got some results. The same things about the treatment protocols were constantly changing. The things about the isolation, home isolation is also under a big question mark. Initially, it was told as 17 days, then 10 days, then 14 days. And now in Mumbai, at some places, the home isolation is prevented by the government, that you should not isolate patient for the home isolation. Even about the test, which is not to be done at the time of discharge, was announced in the month of May. But still we see that many of the patients, especially the VIPs and politicians, are tested again after 10 days or 14 days to see whether they are cured or not. There was a big problem in data collection also. Many times, even in Pune itself, around 3,000 patients were not registered. Few days back, around 773 patients were not registered in the data, and on a single day they were registered, and suddenly the number of patients were seen high. At Bhusawal, around the 23 swabs were found that they were not sent to the center and they were not tested. So many things came across rather in which the doctors were blamed. The doctors were blamed for everything, every wrong thing, and especially the private doctors. There was constant separation from from government and the administrator on the private doctors for each and everything. Uh, Dear friends, that all the doctors were working, all the IMA doctors were working right from the day one. The Indian Medical Association, especially the Pune branch, we had all our clinics open. Our doctors were giving service in the hotspots and containment zones with the help of ambulance. But nothing was rather praised by the government. But we were working, and we were rather served notices that why your services are not, you're not giving the service. Then for the government doctors also, all those residents, which are always were the main backbone of this treatment care, where at many places the salaries are not given. And as I told you that many of our private doctors worked for the government, from some for 2 days, some for 3 days, some for even months. But till now, nobody is given the remuneration. All these things were taken by all the private doctors were treated as criminals. They were not called. There were no discussions. We were sent just the notices, the court sends the summons for the criminals or for the any court matter. The acquisition of hospital beds was a very big problem. The capping of the charges charges in Maharashtra state were capped at 25% of whatever the expenses we require to run the hospital. Initially, we were told that this is the day, this is not a charity, you have to sacrifice for the humanity. We sacrificed, but at the end, we came to know that this is really a bad thing. And many of our hospitals in state of Maharashtra are on the verge of closure because of the lack of finances. On one side, every charge was capped. The charges of laboratories were capped. The charges of the diagnostic procedures, CT scans were capped. The charges of plasma were capped. All these things was done, and we were not allowed to maintain our day-to-day expenses, and it was very difficult for many of the hospitals to survive. There were illogical statements all the time from the government, from the press, that the private doctors are spreading the epidemic. The private labs are giving wrong results. There is if you diagnose a patient by CT scan, that is the wrong thing. You have to do the COVID test. If the COVID test is positive, if the RT-PCR is positive, then only you can treat the patient as COVID patient, because we have seen from our friends in UK and US, the diagnosis on CT was sufficient to treat. So many of our stalwarts were suffering from all these things. And the last thing is about the deaths. As our Honorary Secretary General mentioned, that around more than 600 doctors died. Our count, there was no, to our misfortune, that there was no count from the government. The government does not know how many doctors got affected, got infected, and died. Indian Medical Association throughout the India, IMA Maharashtra, we did our own survey with our friends and our branches and all the presidents. In Maharashtra, right now we have around 63 doctors who died. All over India, around 1,000 doctors died. And in that, the main bad thing, that most of those doctors were general practitioners. The 60% of doctors were general practitioners. And the death rate, which is 1.5%, is in India as an average death rate. In doctors, the death rate is 10%. So that was a very unfortunate thing. Dear friends, there are so many things we can talk, and we can go on talking about it. But the main thing is not the pandemic of COVID-19, but the way it is governed. It is the policy actions by government of India and all these state governments is really bringing tears to our frontier warriors. Thank you very much.
Thank you very much, sir. You started right from March, I do remember, and a lot of issues were there to the topmost government level, and you stood strongly for all the things. We are really indebted that you have done everything from the early, I would say, emergency response to right from the treatment part. There were very issues. And lastly, up till vaccination also, there were a lot of problems in vaccination. And you had done, I would say, the best for it and supported the doctors in whatever way, right from, I would say, the lockdown period till now. I'm really thankful for you in supporting, and still you will be with us, whatever happens. Definitely, I would say this is the day that we are going now for, I would say, very less. I would say the cases have been reduced also. And I don't know whether the second wave will strike or not. For this, all of the international faculties are there to discuss. Thanks a lot, sir.
Hello. Hi, Rajan. May I just speak for a second?
Yeah,
May I?
sure.
Okay. Dr. Avinash, before you leave, I just want to let you know that I think you really brought tears to my eyes from what you've defined as the mishandling of unfortunate loopholes, if I may, in a very least way that I could say. Obviously, there has been a whole deal of confusion across the world, even in the US and also in India. But I thank you, and my humble regards for the warriors and the martyrs, if you will, from India as well as in the US and the rest of the country. I think we hold that banner, and we'd like to continue our work as inspirationally as Dr. Ashokan had also mentioned. Thank you.
Thank you very much, sir. Thank you.
And
Thank you,
I echo that, what Dr. Shara Jaitley had said, instead of repeating the same thing. Thank you for the hard work that you are all doing in India.
Thank you, sir.
Thank you.
Thank you, sir. May I welcome Dr. A.K. Ravi Kumar, Secretary from Tamil Nadu, Dr. S.V.K. Prasad Reddy from Andhra Pradesh, he is the president of there, Dr. Braj Kishore Dash, Dr. Ujjwal Sen Gupta, president from West Bengal. Welcome, sir.
And also our Vice President, Dr. Sanjay Patil, and Padma, Past President.
Welcome, sir. And welcome, madam. May I request Dr. Meenakshi Deshpande to introduce our dashing dynamic leader, Dr. Ravi Wankhedkar, sir, please. Thank you, Meenakshi, madam. I'll take over. I don't know if there's some problem. I don't think there's a way to introduce Dr. Ravi Wankhedkar, a man of, I would say, national president. He's MBBS, practicing surgeon and anorectal surgeon since last 30 years. I am a national president since 2018. National Secretary at IMA, National Hospital Board of India, 2014-16. Ex-member Maharashtra Medical Council, 2011 to 16. Member of Board of Examination, MUHS Nasik. National Chairman IMA, AMS, 2013. President of Dhule District Basketball Association. Medical activist and leader as a medical student, resident doctor, and I would say one of the best medical teacher also. So I request our dynamic leader, Dr. Ravi Wankhedkar, sir, to take over. Dr. Ravi, sir.
Thank you, Dr. Rajan. You'll have to excuse me for my video, and I have to bear with my photograph only. I have certain bandwidth issues. The respected NP, Dr. Rajan, HSG, Dr. Ashokan, who has just left, my dear college friend and state president, Dr. Avinash, my co-panelists, Dr. Peter, Dr. Sharad, Dr. Inder Mohan, the lovable and affable president of IMA Pune, my dear friend, Dr. Aarti, my dear friend, Dr. Rajan, who has been taken great efforts in organizing this wonderful event and getting all the people together. The past president, Dr. Sanjay Patil, Dr. Padma Iyer, Dr. Raju Varyani, Dr. Balasaheb Deshmukh, all the other state presidents, Dr. Ujjwal Sen Gupta, Dr. S.V.K. Prasad Reddy, various state secretaries, Brajdas from Odisha, my brother A.K. Ravi Kumar from Tamil Nadu, and various other dignitaries who have spared their Sunday afternoon for this important international seminar organized so nicely by my mother city, which I fondly call the Pune, where my formative years and whatever I have achieved today, a major lion's share goes to my upbringing in Pune and my medical school, wonderful BJ Medical College. So very fond memories, and I'm always happy to join any event organized by IMA Pune. Today I have been, I can see Dr. Meenakshi also now. We were missing you, Meenakshi. I've been asked by the organizers to speak on two topics. I think one is whether there will be a second wave in India, and second, what will be the changes in the health systems post-COVID. I'll try to be extremely brief, as my predecessors have nicely elaborated about the situation and the response in the Indian context. And we are eagerly awaiting for our international faculty to share their experiences with our Indian colleagues. Whether there will be a second wave in India, it is, I think the correct answer is God only knows. Because uncertainty is the hallmark of this epidemic. What is going to happen? No expert can risk his entire career by saying that 100% yes, the second wave will be there and it will be severe and there will be severe mortality. Even the experiences of various countries can't be applied to our country because this is basically a patchy pandemic. Worldwide, the last 9 months experience shows that within a country also, within a state also, different counties, different districts respond in a different way. And hence, we can't really extrapolate the experience of our European friends that there will be a second wave and this surge will be much bigger than the first wave. In the US itself, I think the first wave itself has to subside. So there is no question of second wave. In India, the last 15 days, not only our active cases have declined, but also our positivity rate is now near the WHO standard of 5, which is an extremely good sign. Still, we are seeing a surge in certain states, especially state like Delhi, a state like Kerala, where post-Onam, the greatest festival of Kerala, we saw a surge in cases. Delhi, with the advent of winter and severe pollution, one of the worst cities, one of the worst polluted cities in the world, we have seen more and more cases and more hospitalizations also. Whether this will be applicable to the entire country, we are keeping our fingers crossed. We recently had many religious festivals, and one of the biggest pan-India festival in the form of Deepavali is coming by. We also have to see that certain states underwent elections and massive rallies were held where we saw that leaders in Bihar suffered COVID due to overcrowding. What we expect and what we hope, ultimately we live on hope, that even though there will be a second surge in India, it will not be as severe as what we had in the first case. Secondly, the mortality from the second wave also would be much less. Because now our health systems are geared, the government, with all its limitations and policies, has definitely created a certain health infrastructure, not only for testing, but for treating also. The clinicians are now well versed in treating patients, and a well-established protocol is practically followed throughout the country, may it be public health or in the private health sector. So, with the vaccine still a distant reality, especially even after the discovery of vaccine, vaccination for 1 billion population is a nightmare. The logistical nightmare, the financial nightmare. Till that time, I think we as clinicians should be definitely on our toes all the while, explain to all the policymakers and the community at large the 3 cardinal important preventive measures of physical distancing, hand hygiene, and masking. I think we physicians, we clinicians ourselves, maybe due to the fatigue of 9 months, we itself are lowering our own guard. And I always believe that we clinicians or we doctors are natural community leaders. And people observe us that what this doctor is doing, how is he behaving, whether he is wearing a mask, whether a proper fitting mask is he wearing, whether he is advising. So it is our duty, even if going on to any marketplace or patients and relatives coming into our own clinics, our setups, to constantly remind people of these 3 cardinal preventive measures. That itself would be a great service in prevention of the second surge. Luckily, we in India still don't have a very different strain, which probably now in Europe is facing with the Spanish strain. In Denmark, they are having transmission due to minks. Such kind of events are not seen with the COVID disease in India yet. Even our mortality always has been less, and the mortality rate is decreasing day by day, and the recovery rate is now above 93%. The fear of corona definitely has decreased now, but this decrease in fear has lowered the guard of the general public. We even can't blame them also to that extent, because they also have now they feel they are better than their lives, their livelihood is more important. But while caring for their livelihood, we also should be very, very strict, very harsh on seeing that again and again. I am harping that there is no other vaccine but these 3 vaccines. What will be the changes post-COVID? Yes, definitely the healthcare delivery system will have a total different scenario, especially in a country like India, which will be divided into a pre-COVID and a post-COVID area. If you'll see the public health system, which is one of the unfortunately worst in our country, where hardly 1% of our GDP is spent on health by the federal government. Various state governments also hardly spend on an average 2 to 3% of their state GDPs. This has resulted in the last 70 years of chronic neglect of the public health infrastructure. And even with this scarce allocation for the health, the priorities are very skewed. The government, instead of prioritizing primary health care, goes due to obvious political reasons in trying to announce and establish and spend millions of rupees on establishing tertiary care centers. I think these priorities will have to be changed now, where public health infrastructure, public health departments across the board, across the country will have to be strengthened, and lot of not only money but resources in the form of human resources, not only as epidemiologists, virologists, all these things will be strengthened. The second important thing which we noted in this entire COVID was the over-bureaucratization of this crisis and unfortunate politicization of COVID crisis. When I say over-bureaucratization, I can quote thousands of examples where scientific or technical advice of medical experts were neglected, and the bureaucracy, which is supposed to be the steel frame of India, unfortunately, in trying to gain an upper hand over the medical practitioners, they overlooked this advice, and we saw numerous examples of multiple contradictory advisories coming. I think this needs to be changed. The medical fraternity needs to be given a prime position in deciding upon health policies, and the bureaucracy should limit itself in implementing those policies, not deciding upon those policies. Thirdly, the government will have to spend more and more money on primary health care, because this is not the single pandemic. Even if this pandemic ends, another 5 years down the line, definitely with the current climate change scenario, we are expecting another disease striking in the form of another pandemic. And we have to be well prepared for it. And for that, strengthening our primary healthcare across the country is the need of hour. In the private health sector, the share of private health sector in India now stands around 70% approximately, which is a very unfortunate scenario. The out of own pocket expenses is the highest in the world in India. 72% of the people have to pay from their own pocket for their medical expenditure. 3.3% of Indian population is pushed below poverty line due to an illness in the family. This doesn't bode well for a developing nation who aspire to become a superpower in next 10 years. This needs to be changed, and hopefully it will change. The politicization of this crisis by using or skewed distribution of resources to various states as per for political purposes was another issue. This also has to change, where the political interference has to go away. Another thing, I'm sorry to say this, but our Indian policymakers are very fond of aping the Western model of health system, especially the US model of insurance-based healthcare delivery system. We all know and are well aware of the pitfalls of a purely insurance-based healthcare delivery system. Government is hell-bent on creating this insurance-based system where it is very obvious that the direct relationship between the doctor and the patient is lost, and the profit-driven insurance companies take control even on the autonomy of the doctors. The autonomy of the patients to choose a healthcare establishment or a doctor is also lost. So this also needs to be given a relook. The last few years, there has been a blatant privatization of entire healthcare systems. Last 20 years, they have privatized the entire medical education system. Now, even the district hospitals are supposed to be privatized. The so-called wellness centers, that is the sub-centers of primary healthcare units, will also be privatized. This will not be sufficient because we saw in the initial phases, whatever little public health infrastructure, and even today, mainly the public health infrastructure is serving in this COVID crisis. These policies of over-bureaucratization, politicization, insurance-based healthcare models, blatant privatization, all needs to be overlooked, and a sea change needs to occur. In the private sector also, we as private establishment owners have to change ourselves. The time probably is now over for single doctor or a doctor couple owned hospitals. We will have to think of a group practice ourselves. Few doctor colleagues coming together and starting a healthcare establishment. We'll also have to see to it that we will have to be prepared for such infectious diseases in the future also. Augmented intelligence or telehealth is coming in a big way, and we will have to adapt ourselves to accept this change. The medical education system will also require a big overhaul. This COVID crisis has shown that the over dependence on specialists and super specialists and super sub-specialists is of no use for a country like India. Our focus needs to be in the medical education system to create more and more generalists, empower them so that we get more primary care physicians. The policy of the government to abolish practically the modern system of medicine and create hybrid doctors of various integrative medicine. I think this is the worst step, and India takes pride. All our three panelists are of Indian origin and are shining stars in their own countries. And Indian doctors worldwide are known for their good clinical acumen. Unfortunately, in next 10 years, all this will be lost because our medical graduates will not be recognized anywhere in the world if they are to be taught not modern medicine, but integrative medicine in the form of having only not only modern medicine, but Ayurveda, Siddha, Unani, homeopathy. Such mixopathy needs to be opposed tooth and nail, because it will be damaging the entire generations of our medical students and young students who aspire to become medical professionals. At the organizational level, we should be well prepared now to foresee that more and more regulations, government regulations, will be enforced on the private health sector. The government and the policy makers feel that the private sector in India is highly unregulated. We have already seen various forms of regulations under the garb of this pandemic in the form of Epidemic Act and the Disaster Management Act. Expect that this will continue, and then that the role of organization will come into play. Organizations will need to be more cooperative with each other. Within the organizations, members need to be more united. We'll have to rise above our personal ambitions, personal egos, rivalries. All these things have to be kept aside, and a very strong united association will be able to fight all these draconian government regulations and the policy changes which the government is envisaging. At a research level, if you will see, this pandemic has become an infodemic, as very rightly said by our WHO Secretary General. Various research papers which were later on found to be fraudulent. The culture of research and the accuracy of research, the trustworthiness of research itself has become very dubious now. Prestigious journals like Lancet, NAGM had to retract their own articles. We are seeing that the pharma industry, unfortunately, is having a lot of influence on the research, so-called research papers coming out of various quarters. All these things will also have to be taken care if we need to have a proper research and things coming out of it. The over-commercialization, which is happening now, also need to be checked. All in all, I would just like to say that there will be drastic changes. We will have to be well prepared to accept and don't change. We will perish. But I'm never cynical in spite of all what I've said. We Indians have great adaptability. Our word jugaad has found even place in the Oxford Dictionary. So we are very well at adaptability, and I'm very sure that the medical fraternity, which rose beautifully, not only to the doctors, the entire paramedical workers, they all healthcare givers, where in spite of total lack of support from the government, the attacks, the physical assaults, the legal assaults on the medical fraternity, we have done our job beautifully. And the result that the pandemic in India is slowing down to a great extent is only and only due to the efforts of all healthcare workers. Because initially, as was rightly put up, and the figures are much more, this is just the official figures are tip of icebergs. Because the very conservative estimate shows that more than 20,000 healthcare workers in India were affected by COVID. And if you'll add to their families who have been affected of healthcare workers, this number will rise. And more than 1,200 healthcare workers have succumbed to this disease. And unfortunately, especially for the private sector, there is no help seen from the government side. In spite of all these difficulties, we have done a good job, and we will be doing our good job. Once again, I thank IMA Pune for this wonderful webinar, and I wish you a very, very happy Diwali. Stay safe, don't burst crackers. Jai Hind.
Thank you very much, sir, for a very excellent presentation. And we are fond of the word jugaad, adaptability, and the medical fraternity will keep rolling. because of, I would say, leaders like you to guide us, we will definitely make an impact on the world. You being a world treasurer, I would say for a medical association, we have very high hopes that at least government and you people can do a lot for our medical fraternity. Thank you very much, sir. Now I request Mr. Deepen Mehta, COO of DigiShield, to give his lecture on digitalization of medical records and its importance. Mr. Deepen Mehta, please take over. Thank you, sir. Just a second. Can I welcome Dr. Anup Nigam, President, IMA MP State. Welcome, sir. Dr. Dipenji, please continue. Thank you.
Thank you, IMA Pune. Thank you all the speakers. Thank you all the international speakers for joining with this webinar, and special thanks to IMA Pune for giving DigiShield opportunity and organize this webinar. I will just let you know about the digitalizing and the practice of the doctors. As in current situation, you can see many of the doctors have started using video consultation because of COVID pandemic. Basically, in India, still more than 80% of the doctors are not into digitalization. As if we compare to international in foreign countries, at least more than 90% of the doctors are adopting some digital platform for prescribing and teleconsultation. But in India, there is lack of digitalization due to various other challenges. So one of the major challenges is capital and awareness. So even doctors are not aware about the benefit of the digitalizing their practice in India, and also it's require a huge cost to implement the digitalization. It requires computers, laptops, servers. So considering all these challenges, DigiShield have built a software which is available free for the doctors for the lifetime, and it's very easy to use and it's very convenient. In current situation in India, the doctors are just used to use write the prescription on the prescription pad, the traditional way they are writing, and giving the physical copy to the patient. In such cases, it finds difficult for the patient as well for the follow-up visit. If doctors have done a follow-up visit for the 2 days, after 2 days or 3 days, so in such situation, if patient forgets the prescription hard copy, so it finds difficult for the doctors to give the further medication. So through DigiShield, if doctor has given the prescription through a DigiShield and patient forgets the physical paper for after 2-3 days or their follow-up visit, so doctor can view the entire patient's medical record, patient's medical history, the previous medication, entire medical history can be viewed by the doctors, which helps the doctor to also maintain the relation with the patient. Even in currently, the doctor are doing video consultation through WhatsApp and giving the prescription in WhatsApp. So in such scenario, there is a risk for the doctor. What if patient has done a video consultation and doctor has patient forgot to make the payment, or patient has not done the paid the consulting fees? So in such cases, it's a risk for the doctor. So through DigiShield, if doctor has done a video consultation through DigiShield, and patient will receive the SMS of the prescription, but patient has not paid the consulting fees, and unless and until patient pays the consulting fees online, patient will not able to view the prescription. So if a patient clicks on the prescription link, it will generate a message to the patient that your so-and-so consulting fees is pending. So please pay the consulting fees to view your prescription. So DigiShield is very helpful for the doctors, and it's available free for the lifetime. Doctors can download from Android as well as iOS App Store. Would recommend doctors to start digitalizing their platform. And also, doctor will receive a digital consent of the patient before doing the video consultation or teleconsultation. So, which also helps doctor to safeguard them from medico-legal as well. So, thank you. If you have any question, you can log on to www.digishield.me, or you can always contact us. You can also reach us. If you have any queries, you can also post your question in Q&A session. We will take the Q&A session at the end of the all the panelists. Thank you.
Thank you, Dipenji, for briefing us about DigiShield and downloading of software. We are really grateful of you to support us in each and every 10 to 15, I would say, webinars conducted by you throughout Maharashtra. And it was excellent presentation. Thank you. Next, I would request our stalwarts from international faculty, Dr. Inder Mohan Narula sir, to join and brief us on, I would say, sir is a team leader, Global Fund from LFA, Ulaanbaatar, Mongolia, and adjunct professor, School of Public Health, Mongolian National University of Medical Science, Ulaanbaatar, Mongolia. Sir has done his Master of Tropical Medicine from Liverpool School of Tropical Medicine, University of Liverpool, UK. Sir is Masters of Public Health, Program and Health Services Management, International Development, Training Material, Manpower Development. Sir has MBBS from GMC Aurangabad. Sir has served in Armed Forces Medical College. Experience for about 14 years in the implementation of primary healthcare programs, 20 years experience in strengthening health management systems, 8 years experience in disease control programs such as AIDS, API, malaria, and lots of that. 3 years experience in the implementation of family planning programs, 18 years experience in program management, including M&E, 18 years experience sector-wide strategic planning, health sector reforms, 16 years in community participation, organization development, 20 years training of healthcare workers, operations evaluation related research. Sir is a technical advisor to the Ministry of Health in Mongolia. Sir represents Japan, but he had gone to Mongolia and Mongolian government told them to give the support for the same. Is a multilateral donor agencies in the health and related community development. I request Dr. Inder Mohan Narula sir to give us a lecture. I would say very first opening of our lecture series. May I request Dr. Inder Mohan Narula to take over this session. Sir is going to speak on early policy actions and emergency response to COVID, experience and challenges. Sir, thank you. Please continue.
Thank you very much for this opportunity. Esteemed colleagues, members of the Indian Medical Association, leaders, policymakers, decision makers, Madam President from Pune, IMA Pune, as well as Dr. Rajan Sancheti for making this possible. We did this work quite recently because when the pandemic started, I was initially in Japan and then I arrived in Mongolia. And immediately after my arrival in Mongolia, the borders were closed. And so I'll give you an overview of how this whole thing progressed and we will share this with you. This is a map of Mongolia. It gives you quite a big, you can see on the northern side, the longest border with the Russian Federation and an even longer border with the People's Republic of China. So you can imagine that once the pandemic began, it was quite a serious concern as far as Mongolia was concerned. Part of the reason of why it was such a concern is because the population of Mongolia is quite small, 3.3 million people, and they're very widely scattered. And 1.4 people per square kilometer. It is therefore the country in which the population is most sparsely distributed. Even though Alaska has got a much more sparser population, more scattered, it is not a country. So therefore Mongolia takes that pride of position. It is a low middle income country, and as mentioned, longest chairborne. But we started activities with regards to controlling the case, COVID, very early in January. Mongolia has a disaster prepared legal framework. Before I go into this detail, I'd like to give you a caveat. Mongolia has a legacy of Soviet oversight. They were part of a satellite state of the Soviet Russia, and therefore have a very strong centralized system of governance. And it is very widely spread, and that they have facilities based on the Shemasko model in all the locations, and it's all very centrally managed by the Ministry of Health. All the services are provided and paid for by the government. The private sector was very small, but over the recent years has begun to grow. Before COVID-19 was declared as a public health emergency of international concern, Mongolia decided that they were going to act. Although there were no travel restrictions recommended in early 2020, the Mongolian authorities orchestrated a unique stepwise travel ban, early closure of educational institutions, and aggressive promotion of public awareness. As indicated, a population of 3.3 million, widely dispersed, harsh continental weather, long, severe winter, temperatures going below 30, sometimes even up to minus 45. Half of the population lives in the capital city, and in large peri-urban areas. You can see a picture of a traditional dwelling, which is often found around most of the city of Ulaanbaatar. In the old days, the central part of the city had apartments where most of the government functionaries and apparatchiks used to stay, as they were connected with the Russian system. Most of the gers, as they are called, the traditional felt, have extended family living in each of these gers. So we realized that if we were to have this isolation, containment strategies based on self-isolation, this would not be practical as far as Mongolia was concerned, because in that one single ger, there are sometimes one, if not two families living together. In the winter, when the temperatures outside are around minus 30, 40, it's very difficult for you to be able to stay outside and self-isolate yourself. So therefore, other rigorous nationwide needed. Secondly, Mongolia has a very high literacy rate, legacy of the Soviet area. Female literacy is 96.4% and male literacy is 93%. This has significant implications of public education and understanding of national and local public health education initiatives. 2.5 million people use mobile phones, 70 of which are smartphones, good for the dissemination. In 2008, the poverty rate was 28.4% of the population, which is poverty line being below $1, and 9.5% employment rate for those aged 15 and above. Risk factors in Mongolia are cardiovascular disease is the most common risk factors. NCD is also leading cause of morbidity. Half the population is overweight, obese, and ischemic disease. You can see the percentages. Chronic obstructive pulmonary disease is about 10%. Aged older, 2.3%, a total population of 77.64. These are more recent figures. Other factors that impact on the spread and the morbidity and mortality of COVID-19. Poverty, very high consumption of red meat, which is a majority. When you have 6 to 7 months of winter, it's very difficult to grow things. And so a lot of it is based on eating meat from various animals, cattle especially. Very few fruit and vegetables, and lives have become more and more and increasingly sedentary since there's not much herding and taking care of. People have moved into the cities. The emergency response system, Mongolia is currently undergoing health system reform nationally. There are approximately 12,000 doctors nationwide, one physician for 283 20,000 middle-level health workers, including auxiliary health workers and technicians and radiologists. There are approximately 12,000 nurses and a high ratio of doctors to patients. This is the legacy of the socialist era. Infrastructure and facilities are widespread, but they are mostly inadequate and not well equipped. But the capacity of the intensive care units is remarkably good. There are 70 intensive care unit facilities countrywide, 349 intensive care unit beds, 443 critical care ventilators. This translates to 11 intensive care unit beds per 100,000 inhabitants. The response to the COVID outbreak. In early January, several weeks before the WHO's announcement of the COVID-19 pandemic as something of international concern, the government initiated precautionary measures based on its disaster protection law. This was enacted in 2017 and established a state emergency committee. The National Emergency Management Agency and the State Emergency Committee in emergency policies via the government of Mongolia and the regional emergency committees. This was enforced through a unified focused administration of the COVID disaster management, working through the Ministry of Health, the local governments, and the local health departments, both in the state as well as at the local level, the district level. This is an overview of when we started. It's a long one, so I will not go through it. It's just a sort of summary, but most of the initiative and activities were started from the 6th of January, and they carried on through. This paper, of course, was published in April, was submitted in April, but anyway, I will cover when I go through the rest of the paper. You can see there were many actions that were quickly taken by the government, and almost all the local governments and the state governments participated. International travel was also restricted, and what has happened, and I'll show some more information on that. This was the response, the suspension of the travel. January 30th, declared public health, then Beijing, Hong Kong, and Wuhan travel was suspended. Tokyo and then Bangkok, this time on the 19th of February, Incheon and Busan, Irkutsk and Ulan-Ude, and then finally on the 11th of March. On the 10th, we had the first imported case in the country, which was a French national, and then from 11th March, borders have been closed, and they have remained closed since then. They have, at this moment, the government has decided the borders will remain closed till the 31st of December. There are some chartered flights that are for repatriation of Mongolian citizens, and when then there is some exchange that is happening with regards to diplomatic personnel and agencies like the UN agencies and some international agencies that they staff. They can travel with permission from the Ministry of Foreign Affairs, also with the Ministry of Health and the SEC. Major public engagements and gatherings were cancelled. The annual celebration that the Mongolian New Year was also prohibited. This is a huge event. It is one of the signature events of the Mongolian culture, and these were all cancelled, and there was a good response and everyone adhered to that. Advertisements were promoting national celebration replaced by public awareness. Domestic travel was completely prohibited. I was here at that point in Mongolia at that time, and there were no cars going between Ulaanbaatar and the provincial capital for full 2 weeks. This has never ever happened as far as the Mongolians are concerned, but the fact that it was enforced was a major achievement. Travel restrictions were again put into place when the first case of COVID-19 was announced. Notably, all educational institutions at all levels were closed. Traditional teaching was replaced by distance learning with the support of UNICEF and also by the government, the Ministry of Education. And before there were any confirmed COVID-19 cases, kindergartens, primary schools, secondary schools, university, vocational schools, and libraries were also closed. All educational, both public and private, initially closed till March 2nd. They were extended, and all annual and exit examinations for the year 2020 were cancelled. However, in September 2021, the schools were reopened and the universities were reopened in October, the middle of October. Early public engagement was done through the SEC and the Ministry of Health. They initiated a one-window policy. We realized, the Mongolian government realized, along with WHO's support, that there is a danger of what you have referred to as infodemic and lots of through the social media. So the SEC established a one-window policy so that information and announcement would only come from one source. And at this meeting, you had people from the Ministry of Health, the SEC, the National Management Agency, WHO, the National Communicable Disease Control Center. They all came together once a day around 11 o'clock, and they made a public broadcast. This consisted of updates, self-isolation, quarantine, test results, suspected cases, health recommendations, and global status of the epidemic. Frequent text messages were, everyone received text messages about the three, taking care of them, washing hands, wearing masks, and avoiding, and all four mobile telephone carriers. Alert messages, avoiding unnecessary domestic travel, isolation, travelers, nutritional advice, personal hygiene, and protective measures. There were no general lockdown imposed on the Mongolians in the sense that everything was shut down. We never announced it, but there was where businesses where physical distancing was not possible, they were closed. Entertainment, nightclubs, bars. The public broadly responded by taking precautionary measures and undertaking increasing their protective behaviors. The wearing of masks was widely adopted. In the past, they never did that, but now they are seen on streets and workplaces. Shortage of face masks led to the emergence of homemade fabric, which was strongly supported by the government. One of the things that happened was state inspectors were ordered the organization businesses not to provide any services to people who were not wearing face masks. Hospitals were check the temperature, the infrared thermometers, unnecessary visits to health facilities were avoided, and hand sanitizers become very popular in all service customer areas, offices, everywhere where you walked in. The Mongolians have the buildings, because it's very cold, most of the time the doors are much smaller, especially since 7 months is winter time. So you have to go through a gate and there's always a guard sitting out over there. So the perfect place to have, check whether you're wearing a mask, and if there was need for any hand sanitizers, they were available. Case surveillance system, a structured surveillance system for contact tracing was set in place. Mongolia has been pretty good with data collection and surveillance because we've had cases of outbreaks of plague because of the marmot population. There have been a number of other outbreaks such as brucellosis and a few other. We had the bird flu earlier, and so there was a system that was set up. So Mongolia, because it's close to both Russia as well as China, is very aware of a structure. HIV was also a major concern, and tuberculosis and the increase in the number of tuberculosis. Mongolia has got the third highest in the Pacific region prevalence of tuberculosis. So suspected cases and those who had contact were identified. There were 3 criteria for case handling categories: suspected, confirmed, and individuals who were at a high risk of being infected. All confirmed suspected cases and primary contacts were hospitalized at the National Center for Communicable Diseases. Primary contact was within 1 meter of the patient who had 4 days of infection before first appearance of clinical system. Also, legislation was approved with criminal charges and sanctions for misreporting and intentionally falsifying health conditions, or people trying to hide and not wanting to come up and be identified through the tracing mechanism. Laboratory testing was done by the National Influenza and Center Laboratory and the National Center for Communicable Diseases, technical guidance from WHO, and Japan, National Institute of Infectious Diseases, Tokyo, Japan. All incoming travelers, so far more than 8,000 now. This was at the time when the paper was written. Now it's approximately 37,000 have been tested throughout their quarantine to ensure accurate establishing of the status. Early emergency preparedness for testing was done. I won't go into the details, but there is anyway, it's on the, and widespread community testing, however, was not required because there was no documented community transmission given the rigorous requirement of the contact tracing and testing. As for the community testing, routine sentinel surveillance was collecting on the average 200 nasopharyngeal samples each week during the COVID times. Random community sampling was also done at various sites, particularly in the city, since more than half the population is here. Mongolia has done, as of June 1, 16,000 tests, but now, as of 6th of November, there have been 92,272 tests, 1 confirmed case per 88 tests, or 1.13% positivity rate. 550 tests per 100,000 population. Now, as mentioned earlier, 92,274 tests as of 6th of November have been done in Mongolia. Increasing capacity of the healthcare system, approved the procurement and equipment for preparation of a 300-bed hospital. Since the February, isolation camps have been prepared. Mongolia has a very small capacity, and if they would get overwhelmed, there would be a big challenge that would happen. And so they needed to build capacity, and therefore they began the procurement and equipment preparation for 300-bedded hospital. Isolation camps have been prepared. Mongolia has a policy of 21 days for isolation, quarantine, and 14 days isolation after that. So a total of 5 weeks is what they do. And because the space for isolation was not possible and people cannot isolate themselves in their gears and in the small apartments, these camps were created, private hospital, resorts, holiday camps. Healthcare system is heavily dependent on the government budget and is nearly universally acceptable. Many of the services are covered by government, from the government budget. And there is also a health insurance system that is provides additional support to the government and to the government hospitals. Private sector is relatively small, so most of the services are provided through state budgeted hospitals and health facilities. COVID-19 healthcare and isolation quarantine services are free. The only thing that people have to pay is for their meals. Overall, COVID health-related healthcare delivery has been made universally accessible. These are all the actions that have been taken since January of this year. The first case was an imported case that happened on the 10th, and somebody came in from Moscow, and they found, so all the people on the plane were told to isolate themselves and report symptoms, but some did not comply. This particular person did not. And so he was identified in one of the provincial areas, and a nasopharyngeal sample was sent to testing. After he was confirmed, he was placed in a quarantine camp and then brought to the hospital. And all the people that were connected to him, through the airport, all the people who were on the plane and people at the airport itself, the staff, they were all contacted, traced, and isolated in their respective locations. Sorry. The National Center for Communicable Disease confirmed 16th and that all 181 primary contacts of these patients had tested negative and were being observed in the quarantine and isolation camps. The National Center for Communicable Disease is the key agency that is responsible for clinical management, contact tracing of suspected and confirmed cases. They have a department of early recognition and response. This has been in existence since Soviet times, well, even before the 1990s, early 1990s. And they've been doing contact tracing through multidisciplinary approach. So the system was prepared and has been very comfortable with doing contact tracing and reaching out, especially when there are outbreaks. They have challenges with contact tracing with HIV and sometimes with tuberculosis, which are routine diseases, and they keep happening. But whenever there's an outbreak, the system is geared to respond very quickly. To date, there have been 3,302 patients that have been placed in quarantine, 21 days in the hospital setting, and more than 32,200 people were in isolation for 14 days. As of the 8th of November, and I was fortunate to be able to get this information from some colleagues in the Ministry of Health, there are 361 active cases, 360 are imported. There was one nurse, as the day before yesterday, who was infected. They are still testing. She is tested positive, but they're trying to figure out how it happened. And as far as gender is concerned, twice as many men as women have tested positive. Currently, there are 314 patients from this group that have been cured, discharged, is fully recovered. 45 are in clinically stable position, 4 are serious. No confirmed COVID-19 admissions to intensive care units or deaths so far. Challenges and unintended consequences. There are some disadvantages and unintended consequences. Educational goals. Mongolia has a high ratio of schools, universities. As you can see from the literature, education is very highly valued. Suspension of face-to-face teaching resonated across all education. Unintentional violation of the children's right, neglect and difficulties in meeting parenting duties, and at the same time, the home confinement has affected the physical and psychological well-being of the children and adolescents. UNICEF stated the closure of the schools and kindergartens put many children's safety and well-being at risk. lifestyle changes during such confinement, physical reduction. You're all aware of that. I won't go through it. Use of the children confined to their homes and forced to leave. There was a increased number of unintentional injury, accidental injury. In fact, 2 days ago, there was four children were, the gear burnt down, and 4 children who were sharing that, 2 families. The parents went out to get some work done to earn money because of the financial situation. They came home to find that all the children had died because of the fire. In response to this concern, introduced distance learning, salary earning patients were allowed to work remotely. The multiple methods of support were provided, paid leave for parents with sick children, reduction of in-office work hours, and a waiver of the social security payment as far as their salaries were concerned for the period of 6 months. Restricted measures were introduced mostly in the urban areas of Mongolia. The rural areas are very small populations, even at the district and capital centers is less than 100,000 people. The largest cities outside of Mongolia have a population. Taranol has about 90,000 and Erdenet has about 84,000 people. So they're very relatively small and they're well located and have apartments. Ulaanbaatar has a persistently high population living under the poverty line because of migration away from the rural areas into the city. Workers continue to go to work because they cannot stay at home to do self-isolation for the nature of the work, or the children face extreme hardship. Groups do not benefit from paid leave and other government support. So this is an area that the government is still dealing with. Serious consequences along, Mongolia is an export-based economy. 80% of its income and its GDP is based on mining, export income, and because of the border closures, this was not possible. Travel bans, thousands of Mongolians in the foreign countries were stranded and they could not return back. Evacuation flights were restricted to 900 passengers per month because of a variety of factors. One of the reasons was there wasn't enough quarantine or isolation camp accommodation and a shortage of flight crew members. Only flights run by Mongolian Airlines was allowed, and there were no other foreign airlines. Recently, however, Turkish Airlines and Korean Air have been allowed to bring people in. The SEC prioritized people with serious health conditions, infants and children. From Mongolia to outside, foreigners were allowed to return after the first 4 months, and they had to get special permission. Of course, the diplomats and members of international agencies were given special permission, but they had to meet the quarantine standards and they had to prove that they had been tested negative. End of May, 344.88 repatriated and 580. I couldn't get the latest figures, but I understand that quite a large number have come, as I indicated previously. Ulaanbaatar is some of the positive benefits that came out of this was there was a considerable reduction of air pollution from reduced transport and industrial activity. UB is known as one of the most polluted capitals in India. I can testify to that. During the whole of winter, I never opened my windows. And it is impossible because as soon as you open them, there is a strong smell, and sulfur and the various pollutants in the air are really challenging to. Increased care for susceptible populations also. People went out of the way to help them and to support people who were at the risk of mental and physical sequelae. Actions to recover the economy. All coal export, which is the primary source for income for the country, was stopped, but they're now returning back. There were tax waivers provided. Many of these policy actions did not really address the partial lockdown exit. There was no to address the lockdown exit strategy, prioritizing containment strategies and extension, and the border controls are being reviewed on a month-by-month basis. The latest decision was made to close the borders, which have been closed since January, since March actually, to complete closure till the end of December. And the government is still thinking the possibility of extending that all the way to the middle of next year. There is a state of high alert. It is still on high alert. Mongolia has been able to successfully defend against an initial community transmission of COVID-19, but the long-term outcomes of these extreme precautionary measures might potentially bring a huge burden to the economy. Smaller population, lessons for consideration by other LMICs. LMICs with smaller population are likely to be overwhelmed, low healthcare capacity, inability to implement adequate quarantine approaches, require stricter and more effective control measures, travel restrictions and prohibitions, and of public gatherings seems to be more important than the lockdown. Isolation and quarantine needed to be facilitated through government interventions, as most of the poorer populations do not have the means to self-isolate at home. If the government had not done this, there would have been much more serious consequences. So this initiative by the government was very helpful. It also made it easier for people to abide by the isolation and quarantine measures because they had a place to go and they were given resources and some support. Only they had to pay was for the food. Adequate resources, questions that were raised. I was listening to the conversations. Adequate resources to develop healthcare systems prior to these emergencies, timely and relevant preventive response, anticipation of the outbreaks are important. This has been done. Mongolia has been fortunate to get the support of the World Bank as well as from WHO and has worked closely with WHO to prepare for this in anticipation. I think the key factor here being is that because it's a small country and is very centralized and has a very active Ministry of Health and close collaboration between the central government and the state governments is an important factor that has helped. That not to say that there are no problems and there are often challenges and that sometimes the state health departments want to do what they want to do, yet there is a considerable amount of oversight and supervision that is held out over there, and there are national standards that are followed and everyone adheres to these. At this time, because the Mongolians felt that they were a small population and they would have a big challenge and they could have really damaged their population and experience a lot of pain and suffering, they were very careful to prevent this from happening. And so far, except for the case that happened a year ago, there has been no internal or community transmission. Every case that we have identified over the last 6 months have been from overseas, those repatriated Mongolians that have come. So therefore, they were captured right at and tested at the border and appropriate measures were taken. Everyone that comes into the country has to go through a minimum of 21 days quarantine. And then depending on whether they become positive or not, they may be allowed to not have the self-isolation. Literacy rate has been a very important indicator, has been a very positive response because of the information and understanding by people. And Mongolians are often very comfortable to say that the importance of universal education has been a key factor in combating health issues and emergencies because information can go and everyone can read this information and pay attention to it and act on it. So, use of mobile phones, radio, television, continued business activities remotely, advanced preparation, robust preventive systems has helped Mongolia to mount an effective response to a pandemic. It is indeed possible. If it can be done in Mongolia, it could be done in other LMICs also. This is the reference of the paper that was there. It was published quite recently, published online on the 23rd of July, and this has been corrected. So that's for your reference. Thank you very much for this opportunity. Whenever there's a time for you, I'm quite happy to answer some of the questions.
Thank you very much, sir, for a very excellent presentation and giving, I would say, in short, whatever has happened in a very small country like Mongolia. We stated about case surveillance, suspected cases, tracing, tracking, and because you mainly told that there was high literacy, and because of that, messages were sent, just we are sending the SMS. Sometimes we are also fed up now that Amitabh ji, someone had commented, we are having messages to follow these SMS and we are doing it. A lot of things have been done from our side also. And as you stated, there were about 12,000 doctors and 12,000 nurses, ICU, about 70 ICUs, 349, I would say, critical care centers were there. And you started first with, I would say, ban on travelers who were stuck up in other countries also. And you had kept alert at Genghis Khan airport. borders were also closed, and mainly because of this, you had, I would say, very less of problems. You, because of being advisor, you conveyed the message of lifestyle changes. Then, as you say that the schools were opened in September and October, we are really, I mean, keen to understand, because now we are doing distance learning and still our colleges and schools are still closed. Now that we are opening the lockdown, lot of things we have to learn also and see that we don't face our second wave and other challenges. So I think there will be a lot of questions from our side, and we'll take it at the last. Thank you very much, sir. Thank you.
Thank you very much. Thank you for the opportunity. Thank you for your patience, gentlemen, ladies, everybody.
May I request our next speaker, a dashing speaker, day in and out. I am having a discussion with Dr. Shara Jaitley. In the night, we are having a lot of discussions, and now that we are here, Dr. Shara Jaitley is internationally recognized for his exceptionally developing clinical and teaching skills and tools, helping and guiding tens of thousands of students across the world. Over 3.5 decades here in the US, Dr. Jaitley's research work is admired, developing identifiers for early detection of cardiotoxicity in CA patients receiving chemotherapy, participating in world trials to help develop very early on using streptokinase, clot buster drugs, meds category to save heart attack victims in TIMI trial in 1986-88, and now bearing the fruits all over the world in helping save lives, improve survival in heart attack victims, a great achievement, I would say. Dr. Jaitley has been in the past a key faculty leader at 3 medical universities here in New York, namely Mount Sinai, Albert Einstein, New York Medical Colleges. New York, his work and experience is not only recognized here in the US, but also high demand in India. We are having a lot of lecture series from him, and Europe, UK. He's holding 3 fellowships at American College of Cardiology, Chest Physician, and College of Physicians. Is currently certified for 4 diplomas by American Board of Internal Medicine, cardiovascular diseases, nuclear cardiology specialization, advanced ultrasound, cardiac MRI imaging, and still hold an active India medical license by Maharashtra State Medical Council since 1979. So I request Dr. Shara Jaitley, sir, to take over and give his address. Thank you, sir. Please.
Thank you, Rajan. Dr. Rajan, it's been an honor and a pleasure. I'm humbled to be part of your team. I appreciate the leadership at the IMA, right from the center as well as from the state levels. And I'm proud to be just part of it. As a matter of fact, I was thinking about it in the last few days since you and I have been chatting. I said, look, this will be a great opportunity for us to exchange, not only from India, but also from the world over, including Mongolia, as Dr. Inder has been highlighting us. So thank you for this opportunity. Without any further ado, I'd like to say, first of all, like I always dedicate my talk to my dad, who was an educationist from Nagpur. And of course, he was not a physician, but he was a mineral economist and a great educationist at the Nagpur University. My son, who has really helped me a great deal with my propounding my or expansion of my video teachings, because there was a time when actually I wanted to sort of convey through print. But he and we chatted about it, and then I think small video chapters is the way to go because everybody is so time constrained. And so his idea has expanded. Now we have presence in about over 85 countries through our Meter Health. And that is totally free for all medical students, residents, fellows, and colleagues like us, primarily to see if we can educate the patients, the family, and the physicians, because I have been a very sort of a staunch propounder of right from my 40 years almost here in the US, that I think a patient care includes not only health education, the continuing medical education, which we are doing here through our medium, but also translate that to the patient and the family. What good is it if you and I, we are learning, you know, the high-five medicine and then do not transcribe or translate to the patients and their families? All what happens is we're just widening the gaps. It's very, very important that even a simple thing like an aspirin needs to be told very carefully to the patient. How often one has to take it? Does it have to be taken before eating? Does it? What's the dose? How long to continue? Whether to refill? Are there any interactions? You know, I always tell my medical students and residents, and that's one of the take-home messages to all the educationists out there in the field or in the audience that we have. I'm sure we have some. I think the easiest thing a physician can do is pick up the pen and start writing a prescription. I always tell that to the medical students. But the hardest thing is to put the pen down and not write a prescription. So in other words, you have to think first a million times before you actually, and that's so important, not only from the medical legal point of view, but also the drug interactions we are seeing. We have antibiotics which are just exploding out of nothing. So anyway, so now without any further ado, I'd like to, as they say, delve in the heart of the matter, or should I say, maybe into the matter of the heart, because that's what my topic is relevant to this webinar. And by the way, I should acknowledge, I believe Dr. Shokan left for other appointments, but I think it was a very inspirational talk that he gave regarding the introduction at the time, at the outset, right in the beginning. So that was very, very, and of course I did acknowledge Dr. Ravi and Dr. Avinash. So I should say now, if I can have my first slide, if you will. Well, one of the things that I always like to say, you can move to the next slide, if you will. The cardiovascular manifestations and perspectives, experiences from the USA per se. We know that now at this point, so in fact, now for the past several months, since we have known this novel disease that has really fallen from the, I wouldn't say from the heavens, from the hells perhaps, on the entire planet, we have millions and millions of cases now being reported all over the world. In the US, since January 20th, 2020, the first case when that was reported, we are now just about crossing 10 million cases. I was watching it on the television just about now, and we have crossed almost 245,000 deaths, unfortunately. So it's a very, very sad figure here in the US that we are now experiencing, as obviously, you know, shared by other speakers from India. We have a steep rise. We also have a steep rise in Mongolia, which is now, you know, obviously affected. But the fact is that, you know, again, what have you, they're doing the best they can. But in our setting, what we have is we have 50 states, which is a vast country. And unfortunately, every state has its own different ways of handling it. And so the guidelines have not been uniformly sort of implemented, if I may. And that's one of the reasons why we are also seeing a staggeringly high, steep count again. We did have a great deal of, I should say, relief after the New York epicenter, if you will, developed following the Wuhan and following the Germany and Spain centers. New York was the next epicenter in the whole of the United States. And perhaps you read, you saw, and you watched, and you came to know of, it was almost a war zone where pretty much all hospitals were flooded. We had a ship actually, you know, the president mobilized the ship to the coast here, which was converted into a hospital, US Navy. And subsequently, we also had several convention centers, including various stadiums converted into overnight makeshift hospitals. So the attempt was immediately to isolate, quarantine, deal with COVID while you're still dealing with non-COVID patients at the hospital level to an extent. All elective procedures were canceled or deferred or put in the back burner. And as a result, you know, despite all of this, we still were circumvented with these figures, which are very sadly being shown on this. Needless to say, the population is 328 million. So when you translate that 245,000 deaths and go to 328 million, it's almost like 0.74 per thousand deaths. That's a pretty high figure for a developed country. And unfortunately, that has impacted not only in our infrastructure, it has impacted in our economy, it has impacted into our livelihoods. And of course, one death, as they say, is lost too many. Here we have lost as many hundreds of thousands of deaths. And some of the mortality has been linked, I should say, to the holidays, to the long weekends, to the, you can call it the COVID fatigue. People are desperate to get out and stop wearing masks and shake hands and hug and go for their birthday parties and welcome their kids and grandkids. But there is a sense now, I think people are starting to also understand that, look, that fatigue factor has to be overcome. We have to get back to ourselves where actually we can help with our fellow brethren. My heart goes out to the physicians, not only in India, but also in the United States, where I've lost 3 colleagues from my own staff. And unfortunately, they had some predisposing conditions, but the very fact that these things are happening the world over, it is worrisome. And obviously, this pandemic is not going away as a medical. It's gonna take its own time, but we have to be all vigilant and prevent any further further deterioration from happening. Let's move on to the next slide, please. Let's understand what SARS-CoV is. I mean, there are 19 names perhaps for this COVID, but let's call it for our sake, the coronavirus or COVID, whatever you're familiar with. But the COVID virus particle has a predilection for an ACE inhibitor, or ACE receptor rather, I should say, right on the cell. Now the angiotensin converting enzyme receptor is the thing where it sort of goes, penetrates, and docks in. And once it docks in, what it does is it starts disrupting the whole cellular cycle. I'm not going to go into the details of it. It creates a cytokine storm within the cell itself. Leave aside yet hitting the organ and the body. The cytokine storm begins right within that cell, microscopically. And then, while it is still replicating, it is disseminating all these cytokine, what you call tumor necrosis factors, or for the medical students, residents, and fellows who are training, and for lack of words, I could tell you all the possible factors which are responsible for ultimately the storm that occurs within the system. So hyperinflammation next occurs. Again, the body tends to have an inflammation which is a normal response, like anything that hits a myocardial cell, for instance. If you're talking about the heart, it's called myocarditis. So as soon as myocarditis occurs, we know there's an inflammation response, but that is a normal response to but when it hits the hyperinflammatory stage of phase, that's where I think the problems are occurring with most COVID patients. So that's one of the reasons why I think we are also having this discussion. How do we control not only the virus replication, because that is one arm of the treatment that you want to spend a lot of time, and I'll delve into that in the next few slides, but also how to control the hyperinflammatory response, which is responsible for severity of these symptoms as well. So as Dr. Fauci, he's the rock star of infectious disease in the world, as everybody knows him now. I think a 5-year-old kid knows him so well. And he's been advocating primarily, one of the features is that, look, vaccines are yet to come. They are not even on the shelves yet. There are about 8 or 9 vaccine trials going on in the United States. But the fact is that we still have to delve into the fact where we have 6 feet distance, social distancing, frequent sanitizations, wearing the masks, and of course, taking all the hygienic precautions that one takes normally, even for a simple thing like flu, which has been around for years. So the point is that we need to really ascertain all of these things before we can actually even delve onto the treatment. The kidneys get affected, the GI mucosa gets affected, the vascular. So in one way, next slide, please. One of the things that I always say that when the SARS-1 came about in 2010, I believe, it was only affecting the respiratory system. And why? Because the ACE receptors were only prone for that SARS-1. However, SARS-2 is a whole different ballgame. It is affecting all the endothelial systems that we have come to know since January and to November. Only about 8 or 9 months, we have come to know about this disease so much, and yet we are learning pretty much every other hour, if you will. So it looks like I have to change my slides every 2 days when I'm doing another next meeting, because on September 13th, the numbers were only about 3 million cases being reported. Now we have 10 million cases in the US. This was September 13th when I was doing a webinar for the IMA Nagpur. They had 190,000 deaths. Today we are crossing 240,000 deaths. So you can imagine this is just one region of the entire planet Earth where these numbers are escalating so rapidly. So making long story short, on this slide, I just want to say that SARS-2 is affecting every single endothelial cell. Now, where are the endothelial cells? Well, friends, I got news for you. The largest organ in the human body is actually endothelial system. So you can imagine pretty much it's a multi-system disease. And that's why I think we as cardiologists like to call it as a vascular tropic virus, another word for a virus. But I think that speaks of actually what the disease and the phenomenon and the pathogenesis of this disease is. Because this virus travels through the vascular system, and that's where the endothelial lining is in every single capillary, in every single vasculature, if you will, right from head to toe, you can imagine. However, we are discussing heart today in my little talk here, so I just want to concentrate primarily to the heart. The predilection for certain patients is very, very important. We have come to know that obesity actually after the age and after the gender is the highest risk factor. A BMI more than 40. If somebody has a BMI more than 40 is a high likelihood to spend a lot of time in the MICU, if you will. I hate to say that. And anywhere between 25 to 39 if the BMI exists. So go back and check your BMIs, guys, and have your patients check their BMIs. That's the take-home message, because that's a higher risk than anything else that I'm going to tell you now. Hypertension is a risk. Diabetes is a risk. High cholesterol is a risk. Cardiovascular disease, if you already have one, like coronary artery disease or valvular conditions or heart failure, etc., those tend to again fall into a higher risk factors, but nothing like obesity for now as far as, and we are talking about big time obesity, unfortunately, and those are the patients who have very, very difficult time getting extubated. Those are the patients we have seen. They get severest of the pneumonias, severest of the desaturations, if you will, or all parameters making them vulnerable to go into MICU and be on mechanical ventilators. There was a time in New York when actually, not that we did not have any need for a ventilator while a patient required one. That was for sure, because ventilators started to really churn up so well. All the, I'm sure you heard about that, there are 3 major motor companies, car companies, they shut down producing their cars. And on the contrary, they started churning out all the ventilators and sent it all over the United States. Now we have so many ventilators that they are now being exported out to the neediest of the neediest countries, etc., from Europe to Asia. Anyway, but ventilation was one of the areas which actually dropped the mortality rather precipitously, because we knew the mortality was almost 80–85% once the patient gets into the MICU. And again, the predilection factors, as I've enumerated at the bottom of the slides, they were the ones. Immune compromise, obviously these patients already were on steroids, or they had HIV, or they were immune compromised genetically, perhaps, for whatever reasons. Then obviously there is a special set of those patients who would get prone for infections. Next, please. We have talked about how various holidays, how various events, and I think it's very important for us to understand that there is something called a super spreader event, and then which is more important than a super spreader individual. Remember that. You could be going up and down the elevators and 50% of the people could be asymptomatic. And they may be actually, I call them asymptomatic carriers. If you are very analogous to typhoid carriers, if you will. When I was in India, I knew that typhoid was so prevalent, and cholera and so many others. But the fact is that typhoid is notoriously, as you know, it's an enteric gallbladder carrier state that patients can have for years. Similarly, here in a setting, you could have this asymptomatic long COVID for a long time. We call it long COVID, and many of these patients can carry it for a longer period of time. So that's an issue now that we have to recognize. And that's all the more reason why I think one should be emphatically advocating the wearing of masks, because you don't know who you're sitting next to on a train or a bus, even though he or she has that distance. We don't know who you're actually dining with. It could be only a table away. We don't know who you could be traveling on the plane with, even though they may be 3 or 4 seats away. But the fact is that I think that, and the take-home message out of this slide is really that we need to know that we need to understand that 50% of the individuals, I'm just rounding it figure, it's about 45, but 50%, half the people are asymptomatic to begin with. Then the ones who become symptomatic, there's an incubation. The median is about 4 to 5 days, but it can go up to 11 days. So I put it down approximately 5 days here. 80% of them, they are still mild. They may just have a headache. They may just have a sneeze. They may have just some non-specific cough. A fever is there. And at times, fever then becomes unrelenting. It can go beyond 101, and even Tylenol, like paracetamol, we call it Tylenol here, crocin in India, perhaps. And these drugs also, just simple antipyretics fail to keep the fever down. That's when many of these patients will report to the emergency rooms. So regardless what, and this is where my premise is about health literacy. You could have, I know Inder talked about literacy level in Mongolia. We have literacy level in India. We have a literacy level in the United States. We have a literacy level in UK and Europe. I'll tell you, the health literacy is much, much different than the literacy per se that we are. You could be a PhD, but the fact is that if you do not wash your hands and do not wear your mask, I consider that health literacy to be zero. And that's one of the problems. We need to make sure that regardless what your literacy level is, I think it is insulting to say that you can't wear a mask, that you cannot social distance, you cannot indulge into closed meetings and stuff like that. So these are very, very important times that the recognition of this is so crucial in order to prevent the spread of this disease. Otherwise, this stuff is not going away, guaranteed. This stuff is not going away, because what will happen is you could make it subside in the United States or in Europe perhaps. The next thing is it'll be still brewing and somewhere in Asia. And what do you do next? And eventually you open up the flights, and then again the pandemics begin. Pandemics primarily begin because now the travel are happening so often and so easily. In 14 hours, I could be meeting you in Mumbai. So the point I'm making is if I'm an asymptomatic COVID carrier, I could be straight into Mumbai and land there. And if nobody checks me, I could be walking around. So the whole problems are, the set of problems are primarily because we are not observing the basic hygienic regulations that have been advised. Do we need a national mandation? I don't think so. But I think it's a matter of your own level of, and through these webinars, through these media, we have, that general practitioner has to go back to the villages, to the towns, and wherever else he is or she is. And or if somebody is interacting virtually, even today we have telemedicine, like Inder said, thankfully we have smartphones where people have actually really access to medicine right on the phone. So that's where the literacy level will have to be utilized and say, look, I think I need to watch this and make sure. So this is where we are today. We have almost about like 300 people right now watching us or as part of the audience. And I'm sure every single one of them will take a message home and say, look, not only the frontliners are affected, but even we sitting in our clinical offices, or the nurses, the technicians, the paramedics who are transporting patients back and forth to the emergency rooms, They're all on front line. We have the fire chiefs, we have the police, the social worker. Every single one of them, they are frontliners. I say even the truck drivers who are bringing food to the grocery so that you can go and pick up your grocery. I say even they are frontliners. I say even the UPS, for instance, if he or she is dropping off a birthday package at your door from your grandchildren, you know, I think they are frontliners. And these frontliners, they deserve the best respect. And we need to make sure, not that we can shut down the economy totally and sit in hibernation for months and months. We have to have that balance, no question. One, we need to preserve the livelihood. Two, we need to preserve the life. And that's where the balance is. And I think that's where the discussion is going across the world. Is there a genetic predisposition? Yes, and I think there are some set of patients that are more prone. We have seen African-American population has been slightly more affected than the Caucasian population in the United States, predominantly in the inner cities, New York, Chicago, Miami, Los Angeles, and to name a few. Present health state is extremely important. Like if you are a jogger, you are in top shape, and howsoever old you could be, and you're in good state, the chances are that you might be able to get away with an asymptomatic COVID. Again, I'm not trying to scare and still keep you, but I'm also trying to keep you well informed that COVID is not a deadly disease, but the fact is that we can make it deadly if you don't follow the regulations and we don't understand the predilections here. Next, please. How does cardiovascular impact in the COVID? Now, obviously, you know, chest pain, shortness of breath, dizziness, palpitations, these are some of the symptoms that are commonly present in most cardiac patients anyway. But the fact is that angina or atypical angina can occur. You could have dizziness as a result of lack of volume because the patients do not eat too well, they have a stomach upset for the first couple of days. There are GI symptoms, they don't have any taste. The taste and the smell of the food, as you know, is lost very early on in the syndrome. So that's one of those issues. So patients in general are volume depleted. Now, if you are the volume depleted, then obviously you may have tachycardia, so palpitations occur. So everything has a reason why these patients are presenting for these symptoms. They certainly are tachypneic, and they for want of oxygenation, because now if their lungs start to congest, people start to have the patients, they try to hyperventilate or actually meet the oxygen requirements, and as a result, tachypnea ensues. So many times the oxygenation can drop down to 86% or less. So our goal is to try to maintain it over 90% at all times in order to have the functionality in all our organs. But otherwise, the brain suffers, the cardiac tissues suffer, the kidneys suffer as a result of the severe oxygenation, deoxygenation rather. Gallup's, arrhythmias, and of course, these are common findings clinically that one can see, but you have to very, very be assured that if you are touching the patient, you have to really take time to don yourself with the proper PPEs, and those are fortunately available, you know, here within the United States. And my heart goes out when somebody was talking about how even raincoats have been used, as we heard about it in the earlier presentation. I believe it was Dr. Avinash. But the fact is that it's one of those things that the infrastructure, the availability of the resources really matter from region to region. And some places, I should say, they are being overutilized, but some places they are being utilized optimally. And most places, I should say, they are being utilized optimally. EKG should be done at the outset whenever you're suspecting that there is a patient presenting with a cardiac symptom. Because obviously you don't want to do EKG on all patients, I'm not saying that, but the EKG should be done primarily at the emergency room level. Now, how often, the question, right, how often do you want to repeat an EKG? Well, again, you want to wait for the symptoms and reevaluate, go revisit this patient. Now, many times I personally advocate that the patients should be seen by one provider, whether it's a nurse, whether it's a social worker, whether it is a dietitian, or whether it's a physician or the house resident. The reason is because you want to limit the traffic. And when you limit the traffic, you'll be surprised that you will be able to this is a take-home message again for our frontline providers. And the reason is because you want to not compromise on the care, but at the same time, limit that traffic through the doors, through the glass doors, back and forth through these MICU stations. It's very, very crucial for us that, again, you have the availability of knowing what the saturation is going on the screen, what's the heart rate, is there any arrhythmia happening, the blood pressure is being monitored. So you're pretty much getting all the vital parameters. But once a day or twice a day, if the patient has to be seen, there's one care provider who he or she goes inside and comes back and gives you the feedback of the clinical state. So it's very, very important. We also have a means of actually calling out the patient, and the patient can call at the nursing station and say, look, I think I'm having a little more difficulty in breathing, or I may have to vomit, or whatever he or she is feeling, and nauseated. So immediately somebody can go back and help him or her to that level, or increase the oxygenation level, or adjust the mechanical ventilation depending upon where the oxygen saturation is going. So a lot of those parameters are handily available, and one should be able to utilize. Idea is not to go back in and make 6 examinations and come back and report to your resident and to the fellows and that hierarchy of so-called physical presentation that goes on all day, as we all have gone through our residencies and fellowships, is that needs to be really, that's a redundant thing. And I'm personally more of adding more information to the patient so that we can have a more cumulative information at the end of the day from the patient. And therefore we can assess and make that quick analysis as to what the next steps would be in terms of our therapeutic options. Echo, when would you want to do an echo? Well, echo is an ultrasound test. It requires at least 30-minute contact with the patient, and patient has to be obviously, right on the table, on the examining bed or table, whatever that is, and you're very in close proximity. So the patient and the provider, or the echo technician, or the physician, or the cardiologist who is involved getting an echo, is a very, very high risk, because the exposure, they say, it should be about 15 minutes of contact in a closed setting, regardless of what the PPE is. Even if you're wearing all the PPEs, I say that, yes, you've dropped the incidence of aerosolized particles to a minimum, but still 5 to 6% of the particles are still around in that region, and somehow they may get into you. And again, you could be a transmitter, asymptomatic transmitter, or may actually come down with the illness. So there have been instances where patients in MICU have been doctors, as a matter of fact, and they have been affected. And I'm sure you have similar reports being reported from Pune and Nagpur and rest of the Maharashtra state. Blood levels, obviously, regardless, we know all these patients already have been COVID positive. So I'm not going to go over that. The fact is that HS, or high sensitive troponins, have emerged once again as a winner, I would say, in the race. Why? Because troponin levels, not just one level. If you have a very high abnormal level, it's a given that myocarditis is already there. The myocardial cell is already undergoing that tropical, the COVID cytokine storm. But the fact is that this HS troponin is a marker which will define what the patient's conditions will be in the next few hours, a few days. And that is very, very crucial. So I suggest that HS troponin, a high sensitive troponin, troponin I or troponin T, whatever you're following in the ratios, you could check that and have that on a daily basis or every other day basis, but based on what the patient's symptoms are. If the patient's symptoms are getting better, you don't need to, or the EKGs, you don't need to follow troponins. But if the troponins are very high, then definitely you have to repeat them in a few hours, because that will determine the prognosis. It's a negative prognostic indicator, as we all know. Likewise, it's D dimers, FTP, and the high ferritin levels. The BNP levels are very important from the cardiologist's point of view, because you know that then we can assess the LV function, because troponins will tell you about the myocardial injury. Very interesting. But the BNP levels will tell you about the LV function. What is happening with the myocardial function? So, which somehow is not on the slide, but it may be perhaps my oversight. But BNP is very, very important. So please include that into your armamentarium doing the testing. Next, please. As I said, it's a vasculotropic virus. So a plaque rupture, a thrombotic occlusion, and a procoagulant release has been the premise of the entire pathogenesis of this disease. So very importantly, not only we are seeing myocarditis, which is a myocardial injury and the inflammation, not only we are seeing the thrombotic occlusion because of the procoagulation release factors that occur. And if you have a diseased coronary artery to begin with, that 50% lesion suddenly starts looking like a 70 or 80% lesion. Now that's where the MIs occur. That's where the non-STEMIs occur, ST elevation MIs, if you will, or unstable anginas like the acute coronary syndromes, ACSs occur. So these patients have angina because of that reason. A thrombotic occlusion occurring in a normal artery versus already in an obstructed or non-obstructive artery, if you will. I already alluded to the inflammation and cytokines, so let's move on to the next slide. ACS, we just talked about it, the acute coronary syndrome, and that's primarily because there's a high oxygen demand and a lack of adequate supply, which is it's a demand supply issue within the myocardium like any other cell, and therefore the myocardial cells will suffer an ischemia as a result. Now it could be a microvascular ischemia. It could be a microvascular dysfunction, which may not be ascertainable even on an EKG. But the troponins will show, because all it takes is a few myocardial cells to undergo that disruption of their cellular function, and the HS, or the high sensitive troponin, will start escalating. So it's a very, very sensitive test. That's why I come back to the previous slides, like I said, troponin and BNPs should be followed right at the beginning when you're suspecting a cardiac involvement. Obviously, these patients will be in the ICU, MIC, or at the present time, we call them MICUs. They're all MICUs patients, and these patients are at high risk. And so, but the key is to recognize it. The early recognition is extremely important in these patients, because then you can have these patients walk out of the MICU. Otherwise, they'll be staggering there for a longer period of time, and, you know, and then nosocomial infections ensue and what have you. STEMIs, yes, STEMIs do occur, especially if you have an acute lesion already sitting there, a 70% lesion perhaps, which will say a person was waiting to get a cardiac cath or a PCR or a CABG, because obviously these patients have underlying coronary artery disease. Some of them do. And when they do have that, a STEMI can occur. This patient was supposed to get a CABG, say, for about a week or 2 weeks from now, and all of a sudden he or she comes into the emergency room complaining of chest pain. That 70% lesion has become a 99% occlusion. As a result, STEMI has occurred, an ST elevation MI as we call it. And as a result, these patients may, at that point, you have no other choice but to bring him to the cardiac cath and do a primary PCI. So when you do a primary PCI, again, you're exposing yourself, you're exposing your entire staff, and of course the patient. But the fact is that you have to, I mean, that's where emergency cardiac caths are happening in these patients. The rescue PCIs or primary PCIs, that's the only way to go right now to save COVID patients from having cardiac MIs, because there's no elective procedure. In fact, if somebody wants to study a coronary anatomy in a high suspicious case, and you really want to stratify these patients for high risk, you could resort to doing a coronary CTA. Remember the coronary CTA? There was a whole influx of CTA information in the past decade or so, of 2 decades. So now it's almost 15 years. We have been talking about how CTA will take over from cardiac cath. Well, this is the time where coronary CTA has been very useful. So if somebody really wants to understand the pathology and is in doubt whether or not should we take this patient for cardiac cath, I think you could do a coronary CTA first and ascertain. It's a non-invasive test, and you could get the results while the patient's in the room, and there's not much of an interaction. All you have to do is give an intravenous injection and bring the patient into the scanner, under the scanner. So the whole idea is wanting to do as non-interventionally and non-invasively. And being a non-interventional cardiologist, I come from that school of thought that I think the least invasive action on a patient perhaps is one of the ways to go to in future as well. As you know, many of the surgical procedures right now, pre-COVID, in that stage, we were doing robotic surgery, and we were doing, vascular, sort of valve replacements through the venous approach. So all of that is right now on hold, because you can't do much elective procedures unless and until this COVID subsides and opens up non-COVID beds and non-COVID facilities. Next, please. We've talked about various arrhythmias, but sinus tachycardia is the commonest, and then of course patients can have SVTs, AFib, atrial flutter, and even bigeminis and non-sustained VTs. Now, there was a time where hydroxychloroquine, if you recall that era, for those 5 months or 4 months where there was a whole hue about this hydroxychloroquine is going to be the lifesaver. It costs pennies and we'll be able to control this. The take-home message for the students, medical students, residents, and fellows is hydroxychloroquine has no role. On the contrary, it can cause more problems than have any benefits in the setting of COVID. It has no antiviral activity at all in this setting. Torsades have been reported. Electrolyte disturbances, they compound the problems. And torsade, as you know, is a non-sustained VT, which can generate into a VF. And if that occurs, obviously, the next thing is you're defibrillating the patient. So hydroxychloroquine, and in combination with certain drugs called macrolides, like the Z-Pak. There was a time, I think, a Z-Pak was also being automatically advocated, and some of these indiscreet prescriptions that I hear about from various localities in India and perhaps even elsewhere. I personally feel that that should be really curtailed. We don't need to prescribe so many antibiotics unnecessarily. One, you're proning the patient for drug interactions. Two, you're actually not offering any antiviral, antimicrobial effect for that particular COVID particle. And three, you will end up with nosocomial infections or super infections later on. So what is the point? And then this is besides the cost that the patients have to go through. Like somebody said earlier, one of the speakers, 72% of your 70 or 72%, correct me, is coming out of pocket. Even though there is a trend now, you have a third-party insurance that is traveling from the United States per se, which began about 20 years ago, so-called managed care, and now it's traveling the world. It has hit the shores of India. And I see that because I travel to India a few times a year, not in the past 9 months, but a few times a year. And I've seen over a period of time, this third-party insurance has taken over predominantly, or is taking over predominantly in many India outlets. So the whole idea is that we really need to be very cautiously advocating these drugs. But again, I come back to the same thing. The prescription is in your hand, the pen is in your hand. It's the doctor who has to think before he or she prescribes. And that's the take-home message. So no, say no to hydroxychloroquine, say no to macrolides, especially the antibiotics, and avoid that indiscriminate use. Worry about the drug interactions first, worry about the antimicrobial effect, if there is any that you're offering, et cetera, et cetera. Next, please. Heart failure, very important area in the cardiovascular COVID area. I want to devote a couple of minutes on this. Myocarditis we talked about, but by then the left ventricle function is still strong, and the ejection fraction normally is about 55% and above. As a result, one sees once the necrosis occurs, the myocardial injury occurs, you see wall motion abnormalities. Now they're discernible on an echo. You can see macroscopic.
Sorry to intervene.
Yes. Yeah, tell me the time factor, please. Yes. How are you doing with the time?
Please, 5 minutes to go. Okay.
Okay, so great. Thank you. Thank you for that reminder. I'll move. Essentially, a dropping of the left ventricle ejection fraction one comes across, and that is one of the areas where we've seen the echo clearly is very helpful. Again, very, very discrete use of echo. Like you don't have to do them quite often, but maybe once at the time when you're suspecting that there is a heart failure ensuing. And heart failure implies that patients have all these parameters. I'm not going to go into the detail at this point. Next slide, please. Next slide, thank you. Obviously, the ACS has to be managed with routine heparin, beta blockers, ACE inhibitors and ARBs was always a question. Remember when I talked about earlier the ACE receptors? Now here's the take-home message. People thought about whether we should take these patients off the ACE inhibitors. The answer is no. Leave them on ACE inhibitors they were already on. Leave them on ARBs, the renin, angiotensin, aldosterone receptor blockading drugs. That's the long form. But you have to keep these drugs going. because they're controlling the hypertension and they're controlling the heart failure in these settings. Likewise, it's true, keep the anti-cholesterol agents like a Lipitor, Zocor, whatever the patient is on, the statins, leave them on. In fact, there was a study done by one of our Indian colleagues, Dr. Mehra from Mass General, New England Journal, that reminds me to tell you that 9,000 patients consecutively who reported in the emergency rooms, he just looked at the patients who were on beta blockers, ACE, and statins. That's all. It was not a randomized control trial or anything, just looked at the retrospectively, those 9,000 patients. He found that those patients were doing better than the patients who are not on these drugs. So sometimes the best, I say, sometimes the best antiviral therapy is not an antiviral therapy. That's the take-home message out of that. So in other words, beta blockers, ACE inhibitors, ARBs, they are cardioprotective. Let's try to save some of those patients through that. Obviously, you want to maintain a good oxygenation in these patients. Your goal is to keep it 90 and 95% above. Whatever it takes, whether it's a CPAP or BiPAP or non-invasive techniques or ventilation support if need be. Next, please. Same thing applies here in the heart failure management. As I said, you keep the drugs going. Do not discontinue them unless contraindicated. And of course, keeping an eye on the kidney functions, keeping an eye on the systolic blood pressure, urine output has to be monitored very well in order to keep the intravascular volume in the euvolemic state, because you definitely don't want to have them overloaded. Next thing, you'll be starting to diurese them and you'll be starting all over again. Next, please. We're almost there now. The only antiviral FDA approved drug, if there is one, I would say is remdesivir, and that is the antiviral drug. Again, it's not shown to improve the mortality. I repeat, it's not shown to improve the mortality. It has only shown to reduce the morbidity in the MICU patients by 5 or 6 days, but it is helpful. But these are, again, 28-day studies, first 3-month studies and 6-month studies. And ongoing studies are going on. And we'll know about it in about a year, how this remdesivir has, but it is not really stunningly improving the mortality figures yet. We haven't seen that. Next, please. So the goal is primarily to prevent the replication, as I said, of the virus with an antiviral drug. And the second arm, as I said, is to avoid that hyperinflammation, which could be detrimental because of the cytokine storm. So that's where this role of dexamethasone comes in. Dexamethasone has always been there ever since, I guess, we all were born. So it's been a life-saving drug, and it's back again here, guys. Next, please. Convalescent plasma, somebody said about that. And again, there are several donors. There are special blood banks. And I know Rajan is a hematologist and a special interest with blood banks over his entire career, Dr. Rajan Sancheti. I personally see that there are certain blood banks only which are designated in the US where you can go and donate the plasma. And these are COVID patients who have recovered. They can go in the convalescent phase. You have to be 4 weeks post COVID in order to go back and donate. And those plasmas can be given to these patients. And again, this has been now FDA approved. Have they improved the mortality? No. Morbidity, yes. But the very timely use of convalescent plasma has to be done, especially when you're documenting high titers. Not for mild or moderate disease. This is only to prevent the severity or the progression of the disease. Next, please. Monoclonal antibodies, the president got the monoclonal antibodies, and that was Regeneron, and he felt miraculously like a Superman the next day, as he said it so. And so that was given, but it was given very early on. So monoclonal antibodies are almost equivalent to the plasma that we just talked about. Basically, these are scientifically created antibodies, and they are given. And they can certainly prevent the heart failure, the ARDS, the ACS in these patients, and patients really recover much better. So, but again, mortality has not been shown to improve yet, but that remains to be seen because those ethical trials are still ongoing and we are awaiting their results. Next, please. There's no role about HCQ and macrolides, I've already said. I think we have covered this slide. Prolongation of the QT interval, that is one of the issues which leads to torsade, and therefore all these drugs should be avoided. Next, please. And in conclusion, here we are. Troponins have a huge role, and likewise the BNPs have a huge role when you're assessing a cardiac patient first time in the emergency rooms. You want to prevent the myocarditis getting into the myocardial necrosis and into heart failure later on, and therefore all these dysfunctions that ensue. So your goal is to prevent the progression of the disease. Nothing like preventing the disease per se to get with, but the fact is that once the patient presents with COVID, your goal as a clinician is to try and prevent the progression of the disease, and that's where I think we come into our pictures here. Next, please. Use of CTA we have talked about, and risk stratification is very helpful. It's a non-invasive way to go, and vaccines are still yet to be released. They are there, hopefully by the end of the year or beginning of the early year. But I anticipate, this is my personal opinion, I think they won't be ready until April. Next, please. And as I say, learning never ends. I always tell my children and grandchildren, live as if you were to die tomorrow. Learn as if you were to live forever. And that was said only by our Mahatma Gandhi. Next, please. Thank you for your kindest attention, and I may have exceeded my time a little bit. I apologize for that, Rajan. And do visit me and see me on unimeterhealth.com. My son and I, we own this as a charity work in my stage of life, which I want to give back to my fellow colleagues in terms of patient health literacy, patient education, and of course, continued medical education. This is Dr. Jaitley from New York. Thank you for your attention. Namaste.
Thank you very much for a very excellent presentation. You have covered a lot of topics regarding use of antibiotics, regarding use of retroviral therapy, I would say viral therapy, and troponin huge role. A lot of things you have explained. I need not go in details because we have a restraint of time, but we will keep your take-home message that BMI greater than 40, high risk diabetes, hypertension, high cholesterol, immunocompromised patients. And accordingly, we'll take care of that. And you said about the plasma also, timely use, you said, but it doesn't reduce much mortality. So we are also in dilemma whether to give or not. Lastly, about the dexamethasone, we will ask the questions accordingly. And about monoclonal therapy, which was given to the big bosses, and they somehow death or I would say mortality was not seen much. But I feel whatever we should do in the best of patient survival is the fittest to say. Thanks a lot, sir. And we have to go for, I would say, next lecture. After that, we'll have a question answer session. In that, we can ask questions. Okay, thanks a lot,
Thank
sir.
you for the opportunity.
Next, I'll request our last batsman, Dr. Peter Patel. He's an international director, faculty in disaster medicine, visiting India and Nepal, Birmingham. He's from UK, visiting professor of disaster medicine in Sri Ramachandra Higher Education Center in Chennai, then joint chair of academic board of disaster medicine in Amrita Institute, also in Kochi, India, saving lives project of Rotary Club of Birmingham, Millennium President Award. Is an assistant governor, Rotary International District, is a managing director from PI Group Limited. And I want to remind that last, I think before March, he had come in Bharati Medical College and taught us how to wear this PP kit. So I do remember we had a disaster management workshop in Sancheti Hospital, Pune, so also Bharati Hospital. And it was shocking that we had to wear, and for about 6 months, we had to go in field also for that. And it served a lot, creating awareness and saving a lot of people, I would say. Thanks a lot. I would request Dr. Peter Patel, sir, to take over and address us.
Okay, thank you very much, Dr. Sancheti. I'll try and see if I can share my screen. Thank you very much. Some of the things which I was going to say have been covered in well detail and extremely well by Shara Jaitley, so I'm going to sort of skip over them much later. But basically, just very quickly to introduce, I'm not a clinician like you guys. I'm a microbiologist with special interest in infectious diseases. And I spent 22 years in academia, came out into biotechnology development, host defense mechanism, then into National Health Service, primary care, and looking at sort of the healthcare development other aspect. And I developed interest in disaster medicine, which is my humanitarian project. And we have great partners. Public Health England, one of the rare groups that's a government organization you heard of, who are actually our advisors and development partners. And then we have the CREMEDIN, the Center for Emergency Medicine, Disaster Medicine, Novara, an area which was first very badly affected by COVID-19, and that region is again now getting a second wave. And we have National Association of Primary Care, another of the advisor partner, and not to forget our Royal College of Surgeons, pre-hospital emergency care. So we've got quite a good strong network out there developing disaster medicine, and epidemics and pandemics is one of the parts of our training for the people. So title today, Coronavirus, a Global Pandemic. And I'm going to give you the much broader aspects of pandemics, and particularly on the coronavirus. So, so rather than leave it till the end, thank you very much for that great set of Pune IMA on the left-hand side, the organizers, and equally eminent speakers out there. It is indeed a great pleasure to join this team of international experts to actually, talk to you guys, and happy, not even now, but later on, to support anybody who's interested in pandemics and COVID-19 situation. So my theme is going to be cure versus prevention, a global health challenge. That's what we're going to look at. And the primary aim here is to look at is what the impact of epidemics and pandemics has on not only society, but also the country. And then we're going to look at this COVID-19 cure versus prevention, where are we going? To just refresh people's memory, pandemic, that photograph in the middle, you'll see is the Spanish flu. And that was a kind of hospital they built. Nothing has changed. Similar halls and things, the beds are being put up. Only exception in many of the areas is that they may have some partitions, but we are repeating the same thing. And the good old definition at the time, the Greek, meaning literally all people. But it, of course, at that time does not apply universally, and I'll look at that in a minute. So the definition of pandemic as we have it right now is an epidemic of infectious disease that is spreading through human population across large area. Okay, remember large area. So it could be continent or even worldwide. Okay, but in WHO's term, it has to occur in many regions of the WHO, which is the right-hand picture over there, and the color code into 6 regions. The reason I bring this one up is that people have been waiting. What the countries have done is they waited for WHO to declare a pandemic and left their preparation a little bit too late. What we are saying is that every country, every region must have its own system for global health security. And if, say, for example, Indian states, along with Bangladesh, they can see an epidemic increasing, they can actually call it a pandemic for the region. Don't wait for a third party to declare it and then get your preparedness going. Otherwise, you have seen what happens, in terms of happened with the COVID-19. And at the bottom left, I have sort of put down endemic. Of course, these seasonal flus are usually called, endemic diseases. The reason it's endemic disease is stable in terms of how many people are getting sick, and it's not a pandemic. The reason I bring that up is that if things are not taken care of this pandemic, then COVID-19 can become endemic, creating even more problems for the people. So usually epidemics and pandemics, as you know right now, they have catastrophic impact on a nation's population and economy. Depending on which country is getting the worst hit. So why are the pandemics potentially damaging? Okay, and these are actually, you will see from your own countries around the world, and that first of all, it actually reduces the workforce. It damages the health service. It has got challenges for infrastructure. transport of food, fuel, and including the pharmaceuticals and support, it creates social unrest, which you have seen in many places, including India with the migrant workers, and it has a problem with security. High morbidity, and this is difficult to treat patients adequately. So we have high morbidity, and we also have high mortality. In terms of COVID-19, relatively the mortality rate is lower, so is morbidity is sort of relatively lower in terms of total population, but it's still creating a havoc as compared to many of the other infectious diseases. So here are some of the examples of damage to the challenges to, in fact, the healthcare service and related. Top left over there, that's the Spanish hospital. COVID-19 patients, no capacity, too late in planning, people actually sleeping on the floor. Middle, number of dead bodies out there. I think that was in Brazil, being stored out there. Again, the number of graves in the middle left over there, the second picture on the left on the side. The thousands of graves which have been created. The extreme right, that's cremation in India. The rate of when the mortality was going up, the number of dead bodies which were being cremated was so high. Here's disinfection. And then we have also infrastructure right at the bottom, Delhi being blocked up and challenges. And some of you might have also seen the shocking pictures of many Indian hospitals where bodies have been shown lying around of COVID-19 with live patients on the same ward. So these are some of the challenges which we really have to look at when we are planning for health security. Medical work during the pandemic. Many health workers are affected. They don't become ill, but right now, if say India, 700-800 people are dead, and if, many of them are actually unable to practice their medicine because they're infected. Worldwide, the figures are anywhere between 7,000 to 9,000 dead. But it's not actually been accurately, those figures are not accurate because we don't have those very clearly recorded. The hospitals and healthcare services are overwhelmed. New York is one example. Mumbai, Pune, Delhi, Chennai, I can carry on and name. The hospital infrastructure just wasn't able to cope with it. And at the same time, drugs, food, etc. was limited, and the supplies were affected, and also the cost of drugs actually goes, very, very high. In terms of environment, it's very, very, very difficult to work. Those of you who actually worked with those full PPEs and all the precautions and the heat, it is just impossible. Anybody who's tried it, it's just not possible to work there. So here is another sort of scenario out there. We have hospital beds being prepared on the left-hand side. But here are some of the PPEs. We have the Italian hospital. Look at how many people are required to get that one, to save life of one person out there. And then in sharp comparison, the Indian hospital on bottom left, they hardly had any decent PPEs. During the months of February, all the way up to June, most of them were complaining about insufficient and inadequate PPEs, not fit for purpose. And the one on the bottom right is, I think it's from New York, if I remember right, where garbage bags had to be adopted as PPEs to continue working. So here are really the stalwarts, the warriors who really actually worked hard instead of saying walking away. They said, no, we're going to continue to save lives. So these are the challenges. Refreshing the memory of the people. Coronavirus, large family of viruses, it usually causes diseases in mammals and birds. In humans, there's common cold. There are about 5 to 7. So 3 of them are this common cold. We now have MERS and SARS, and we have SARS-CoV-2. Right at the beginning, when it was said it was called Chinese coronavirus, and WHO called it novel coronavirus CoV. And as they evolved the name, the virus is called SARS-CoV-2, and the disease is called COVID-19. Well, the source is still unknown, possibly wild animals. But now from Denmark, as you heard early on, we have a new variant which is coming from mink farms out there. It is called zoonotic diseases, and SARS, as you know, comes from cats, MERS from camels. But there are plenty of other coronavirus groups which are present in bats and wild animals. In fact, Wuhan has a laboratory or research laboratory which actually specializes in the coronavirus research. So this is a scenario early February 2019. Only about a handful of countries, about 9 or 10 countries were actually affected by the coronavirus spread. And then right now, the figures up there are last night's 190 countries. The figures of confirmed cases has actually gone up to 50 million plus, and the death numbers increased. Mortality rates have still remained 2.5 only. India's is still lower. It's around 1.4. But then I'm not going to go into details of what India's comparisons are for number of cases and mortality, because you cannot compare each country's numbers with the other countries because of the differences in testing mechanism. But particularly in India, the different types of tests and they have been used varies across the states. The number of tests carried out per million varies, and death recording, mortality recording is kind of very, very poor. So you cannot just compare those. So this is what we have. And very quickly, we have the top 10 countries out there. India remains number 3 in terms of deaths, number of deaths coming up there, okay? But it still claims that in all cluster cases, unfortunately, it's not willing to accept that India has community transmission. Some of the medical leads from the government in various states say, yes, we do have community transmission, but we can't officially say that. And that is going to be the problem for controlling the transmission of COVID-19, in India. So let me come up to the main part over here, which is cure versus prevention. What do we do? Option 1, let the spread continue, treat them, and build herd immunity. Option 2 is prevention. So let's look at option 1, cure. Well, currently there is no cure for COVID-19. There's a lot of research ongoing to find effective treatment, but there isn't one. The treatments are supportive treatments and they're treating the symptoms. Antivirals, okay, so we have 2 different types of treatments. One are antivirals, the drugs. The others are immunomodulators. So you have additional support for immune system to fight, which is your plasma therapy, your monoclonal antibodies, and then we have drugs which actually, try to decrease the overreacting immune system. Right now, there are something like 132 potential COVID-19 treatments which the European Medicines Agency is looking at, but none has been approved for general use. So if I look at some of the treatment, remdesivir, it's just been approved on 22nd October in USA, and it is also being approved for temporary use in 50 countries. As Shara Jaitley said, it's not actually the magic bullet. It will reduce the amount of stay in the hospital, but overall, it does not reduce mortality. Micronutrients. A lot of people have been talking about vitamin D, C, and zinc, and a lot of people are actually using it. Unfortunately, it is not a treatment. None of them are actually going to block the virus, but they will improve the functioning of your immune system. Okay, and as of 15th October, there is what we call the solidarity trials, and there are 4 treatments evaluated: remdesivir, hydroxychloroquine, ritonavir, and interferon. And the results were, it had little or no effect on overall mortality, initiation of ventilation, and duration of hospital stay in hospitalized presence. So, as I said, there are not many of the cures or treatment, the magic bullets around. Plasma therapy, published results, no difference in 20-day mortality. But the problem here is that plasma therapy is being used completely blindly by just not looking at what the patient needs and what, how many antibodies are really present in plasma being donated. They've just been collected and then used very randomly. So it will come up with those kind of results. And then we have tocilizumab. Again, it was not effective for preventing intubation or deaths in moderately ill hospitalized patients with COVID-19. It does say that there could be some harm or benefit cannot be ruled out. And then the last one, tocilizumab, it reduces the mechanical and non-invasive ventilation of death by 14, but no mortality, not the mortality by day 28. So again, quite a bit of different ways of looking at, is there really an effective magic bullet treatment cure from drugs or plasma therapy or monoclonal antibodies? The answer is no. Let's look at the cost of the current treatments, okay? So when we're costing the current treatments, one of the models is Rebello's model, which looks at susceptibility, infected, and recovered people. So we have direct and indirect health costs. And then, as mentioned in India and many other countries, we have got out-of-pocket health costs, okay? And to look at the determination of cost, it's a cost of testing and contact tracing, cost of hospitalization, intensive medical care, additional cost of PPEs and safety, the cost of drugs. And I particularly mention the cost of drugs because you'll find that a lot of people in India have complained about black market of drugs, which has also been mentioned by speakers before. And then control intervention of managing diseases and the salaries of the health and care workers. So when we look at the cost, here, our major antiviral, £1,500 for 5 days in UK. In US, it's $3,120 for insurance companies or $2,340 for out-of-pocket. Hospital beds in UK will cost about between $1,500 to $4,000 per day. The government quarantine varies. It can be in some countries it's cheaper, but it can be anywhere between 50 to 100 pounds per day. And then if you look at cost of hospitalization of patients in UK for 14 days, it can cost up to £49,000 out there for that treatment. And then look at the cost of actually on the healthcare system post-COVID. A lot of people who've had sort of severe COVID and have survived, they have ongoing post-COVID health problems, and that can cost that person between £2,000 to £4,000 per year. So that actually adds up and becomes very, very expensive. These are the government guidelines on the cost for India and for 10 days cost. But there are also reports, independent reports, that some very small number of private hospitals have been overcharging their patients in significant numbers. So the bottom line here is, if you let COVID-19 continue towards herd immunity, economically, it doesn't make sense for the individual who's going to pay for it or for the government. The costs are going to be exorbitantly too high to justify. So we need to look at option 2, which is prevention. So prevention and non-medical containment and mitigation must be a major route for any country to fight pandemic. I'm just going to have a bottle of a quick swig of water. So what do we have? We have prevention, medical interventions. There can be prophylaxis, or vaccines. I'm talking about general pandemic epidemics. But in our case, in COVID-19, neither chloroquine nor hydroxychloroquine can be considered as prophylaxis. They are ineffective. Okay, and non-medical interventions. Okay, and they actually have five. We have five different types. One, the state has to look for reduction of risk of transmission. That requires also good quality data collection and communication. Okay, it requires reduced intervals between symptoms and isolation. So detecting, finding the people who have got the symptoms and much earlier isolation for those. We require social distancing and public compliance, which is a major problem. We require disinfection measures, and we have need travel restrictions. So now coming to the vaccine part, okay? Everybody knows you have a vaccine which is very clearly measles. We have an existing antibody. You have maybe chickenpox and that. And when you have an existing antibody against an invading pathogen, then of course you're protected. But when you have a new pathogen which invades you and there's no antibody, then you get infected. So you put in a vaccine against this new pathogen and a new antibody is produced. The problem with COVID-19 is we are not sure in terms of the life of antibody which is generated by natural infection. Several studies have shown that the antibody level drops after 3 to 6 months. So that is a major problem. And we have some cases where second infections have been shown after a few months in these patients. So will a vaccine work? Will the antibody survive? Will you require more than one dose of vaccination? Is a major challenge. Currently, there are 100 vaccine candidates in WHO as of 3rd of November. And I've just actually, there are 47 of them are in clinical trials. And I have no intention of going through all of these. The data is available on the PDF copy on WHO website if anybody is interested in understanding the vaccines or finding out what's available. Okay, in terms of vaccines, Russia and China have begun COVID-19 vaccination. They have not completed all parts of international clinical trial protocols. There are no vaccines currently available which have been emergency use authorization for COVID-19. Okay, all of those ones we are coming up to mention, they are under development and will need refrigeration at temperatures well below 0 degrees. So when the vaccine is available, to get it to millions of people, including countries like India, will require a cold chain. There is a report of an Indian scientist who claims that he has produced a heat-stable vaccine which can be stored at 100 degrees for 90 minutes or 70 degrees for 16 hours. So that's if that one actually comes out successful, then that will be a good innovation. United Kingdom. Well, the news here is that the NHS has already started asking the NHS doctors to prepare for vaccinating for COVID-19 by this December. And they say they have possibly, one of the 3 vaccines might be available. So contracts are going out, plans have been drawn up, and the first group of people who either plan to vaccinate are going to be NHS workers, at-risk workers, and people over the age of 85. Okay. AstraZeneca COVID-19 Oxford vaccine. So how does it work? This virus actually uses proteins from its surface called spike proteins, okay? And this particular COVID-19 vaccine is made up of another virus, adenovirus family, and that's been modified to contain a gene from SARS-CoV-2 spike protein. Adenovirus itself cannot reproduce and does not cause disease. So when the vaccine is delivered into a human body, into the cell, then the cell uses the gene to reproduce a spike protein. And that will trigger the person's immune system against this spike protein of SARS-CoV-2. So if later that vaccinated person comes into contact with the SARS-CoV-2, the immune system will recognize it and the virus will be prepared to attack it. So this is one of the different types of vaccine, okay? There is a social media scare that the virus gene will take over human body, but so far, none of the experiments, none of the trials have shown that a gene can take over human cells, okay? And then the Russian and Chinese vaccines are being used without completing 3-phase trials, heat stable, and then finally, Bharat Biotech's corona vaccine. It will not be ready till February, according to the report. So we still have a long way to wait. So new drugs and vaccines. Well, we have a challenge here. So the number of people given new drugs, okay, so when you start actually giving people either a new drug or vaccine, the number of people given new drugs are very, very small. So if you see an adverse impact, it is limited to the group which already has an illness. But when you start giving them a new vaccine to several millions of people with the hope of limiting the spread, and these are perfectly healthy people, then the adverse impact of this unsafe vaccine could be on millions around the world. Therefore, it's very, very important for us to actually make sure that our vaccine is safe and approved, and there are no shortcuts like what Chinese and the Russians are doing. Okay, so final comments on vaccine, and I'm coming to the end of my presentation. While there is a great optimism for vaccine, which could be available by December, but unfortunately, many experts believe it can take another 12 to 24 months before a relatively safe vaccine is available. So what do we do until then? I've already said we are going to rule out herd immunity, and the reason for herd immunity, which can go into discussion, you'll require 70% of the population actually infected before a good herd immunity will work in a country or a state. And that's going to be very, very expensive in terms of mortality, morbidity, and the health economics. So until then, what we must do is to have strong preventive protocols, as cure or herd immunity is not, a viable option. So looking at the impact of actually the epidemics and pandemics. So sum up, increased morbidity and mortality. It's likely to become endemic, disrupts the health system, increases disease burden and health cost, disrupts businesses and manufacturing activity, changes population profile, damages economy, creates massive unemployment and poverty. Some regions and countries could be isolated as pariahs. Tourism industry will be destroyed. Businesses and manufacturing will suffer, and food and medical supplies challenges will remain. And those are the major problems. So it's best to actually stop pandemics and epidemics right at the beginning, rather than letting it carry on. This is the global health security map, which is in which 195 countries participated. And the ones which is yellow, these countries were supposed to be most prepared for pandemics and global health security. The one with orangish color, not prepared, and the ones with the red, least prepared. And this research was done very recently by the group leading global health security. What is actually shown for COVID-19, every country failed in timely response. So message there is very clear. Don't depend on international bodies to give you warning. Gather the data in each country and region and have your own global health security and national health security in place. There quickly, just 2 or 3 on that one. When that research was done, it says national health security is fundamental. it's fundamentally weak around the world. No country is fully prepared for epidemics or pandemics, and every country has important gaps to address. Countries are not prepared for a global catastrophic or biological event. Okay, the health security capacity, or shown that it is when these are things, they're dysfunctional. Okay, and the countries have not allocated funding nor budgets to fill the gaps. So I'm not going to go through all this. These are some of the challenges of epidemics, pandemics, and it's a question of cure treatment versus prevention. So here it is. My final message is global health security is the responsibility of not only the government, but all healthcare providers, professionals, businesses, industries, and communities. We must work together in partnership to mitigate and reduce risk from future pandemic. And if you really want to see here on the top left, that's the Pune group. And there is our Dr. Pawar and the Rajan, you'll remember that training out there for COVID-19 just done in early February out there. That's one of the Indian hospitals. And then in the middle, that's Dr. Rajan's team teaching people how to wear masks. Somewhere there in the middle, PPE, how to actually use PPE safely. And the bottom right is that responsibility of media and the politicians who do mass gatherings, even in the middle of the biggest pandemic in the country, ignoring all social distancing rules, hardly any masks. So it's a collective responsibility if we are really going to win these kinds of battles, and it can't just be left to Department of Health or number of doctors or nurses. It's just not going to work. And with that, thank you very much.
Thank you very much, sir. Very excellent presentation, start to end, I would say. And you told a lot of things about herd immunity, right from pandemic, where we started, healthcare system, social unrest, high mortality, and about global health security, which is, I would say, a responsibility, and we should be prepared for that. We are fortunate that very first in Feb, we had a good, I would say, workshop at Bharati also I mentioned before, and so also at the Sancheti Hospital to wear the mask. Actually, I've shown the slide also. I'm also surprised how it went, but we had to be prepared, and we were prepared for this. We had been maybe 3 to 4 months in each and every place to create awareness, and we would say that we were one of the best of students that time, so that we could take care because we had lessened all of the fear also. And I would say frontline workers, our doctors, they had opened the clinics, and I would really state that these are the real Corona warriors. About 700 deaths in the whole of the country. Still, we were prepared to fight, and because of that, we are having, I would say, very less percentage of death, and we are third, I would say. We had mentioned there were about 1,234,000 deaths, and we had all of the inadequate PPE, garbage bags, a lot of things you mentioned. Now we have to be prepared also, and will require help all of our stalwarts, those who can help us out for this disaster management preparedness. So we'll go for it also. And now lastly, I would again thank you for taking a great pain and telling us a lot about treatment and other things also. You mentioned about antivirals, stop about the immunity system to increase immunity, immunity boosters, micronutrients, and a lot of things. And lot of use of other things, and plasma also, you mentioned a lot of things also. And we failed somewhere, about 195 countries, but it's, I would say, by chance it happened. And lastly, you mentioned about vaccines. We are fortunate that probably we'll have a mark in December or Jan, and a lot of companies have come forward, and hope we can get it and save a lot of lives. Thank you again, sir, and we'll be with you. And lastly, I would thank each and every faculties, those who have, I would say, excellently presented, as we have now a question answer sessions. May I request Dr. Sanjay Patil, if he is there, or Dr. Padma Iyer, to start the question answer session. A lot of question answers has been answered by our panel team, Dr. Ravi Wankhedkar sir, or Dr. Indran Mohan sir, and a lot of questions are, I would say, put up. Dr. Padma Iyer, can you please,
Yes,
Padma Iyer, madam,
yes.
our past president, she's also a dynamic lady. I would request her to start the question answer session and let us know what are the queries from our distinguished faculties and delegates also. Please, madam.
Thank you, Dr. Sancheti. And it was an excellent international webinar with excellent deliberations by all the faculties. Most of the questions has been answered by Dr. Ravi Wankhedkar sir and Dr. Narula sir, and it has been put in the chat box. Now I have got only 2 questions which are to be answered. Dr. Alpana Soode has asked, are mRNA vaccines are safe? So I would request Dr. Patel sir to elaborate on that.
Sorry, could you repeat that question, please?
Are mRNA vaccines safe?
I'm sorry, I'm not aware of that vaccine. mRNA?
Messenger.
Vaccines, are they safe? Maybe, I don't know. That is what the question is put.
Okay.
Okay, we'll put that. The second question is,
are vaccines safe? Right now, it's not that easy. The clinical phase 3 trials are actually going on, and the international experts are looking at everything possible to ensure that they are safe. Gone are the good old days when we used to actually have attenuated vaccine, or just the antigens extracted and produced, and they were much simpler with the adjuvant. The vaccines are getting more and more complex. And even the phase 3 trials have limited number of people. So we do get some vaccines once they're released into the community which are unsafe. Okay, it doesn't actually affect hundreds of thousands of people, but you will get a very small percentage who will have an adverse reaction. So there is a reporting mechanism to look at it. And I would actually depend on not a country approval, I would depend on international approval of vaccine being safe, in my opinion, before I would take it.
okay, thank you very much, sir.
Madam, can I follow up quickly on that?
Yes, yes, sure.
Okay, yeah, thank you for the opportunity. So, yeah, vaccines, there are 9 trials right now underway in the United States. And AstraZeneca was held off for a week after they reported one incident of spinal issues. But following that, again, they found that was unrelated relatively, and therefore now it's restarted. We do not know yet which vaccine is going to be the front runner. Quick take-home message. We are looking at 2 dosages to be offered, say, even to 100 million people right here within the US first. Obviously, the frontline workers will get it first. The doctors, the elderly, the police, the fire chiefs, and what have you, which we already talked about. So we are looking at 2 dosages times 100 million, 200 million people. Now, look at the infrastructure here. Who is going to administer those 200 million dosages? That will be one way to look at. How are we going to transport these vaccines if they are requiring refrigeration? So there's a whole bunch of issues, not just the safety and the efficacy that has to be demonstrated in the ethically controlled trials. And now we have a resurgence, not a resurgence, I should say, rather reincidence of reinfections, if you will. That is another issue. And there were 3 cases that were just isolated from state of Nevada and 2 from Virginia, only in the last couple of months. And Peter, you might be interested in knowing, being a microbiology specialist, I would say that the 2 out of the 3 cases demonstrated mutant strains. So we are now concerned not only about approving one set of vaccines, but they're looking at trying to see if what if this virus is replicating and mutating by the time these vaccines are on the shelves. Thank you.
Okay, let me respond to that one. Okay. So far on the mutation, what we have with COVID-19 SARS is that most of those mutations are very small. We just change the 2 to 3 sectors of the nucleotide. So the amino acid changes are so small. Not a single mutant so far has changed the makeup of the glycoproteins and the antigens which are expressed. So most of us are confident, particularly with this particular virus, unlike the other DNA viruses, it's most unlikely to mutate significantly unless it's been induced in a laboratory. The natural mutations are going to be very small, and we've been able to track what came from China into Spain, what went into Europe, and through these various mutations. But they are not new variants as such. And the only one which we haven't done yet is the mink one. The mink one has been called a new mutant, new variant. We do not know whether it has got a different antigen expressions out there, different glycoproteins. But the others so far seem to be relatively okay, and the current vaccine trials and current vaccine development, they will actually manage all of those.
As you said, sir, there is 70% if you say the herd immunity. What is the need of vaccination then? If you have herd immunity, is that necessary then? Can we have vaccination?
Let me explain to you herd immunity. This is the biggest challenge. So we have got actually public health experts, and depending on what they're talking about, some of them talk about 10 to 20% of the population having herd immunity, and that will become herd immunity. If you really look at how contagious the virus or the bacteria is, okay, and then its prevalence and what it requires. So imagine, say, you have a population of 1,000 people. Out of 1,000 people, so you can look at the same population, say in Pune city, that cluster. If 20% have got the immunity, natural herd immunity, 80% are not. Okay, so out of that, if 20 to 30% of those are asymptomatic or carriers or infected, all the rest can be exposed. So when you actually look at the movement in the population, if you allow them to go, the chances of these people who are not infected becomes very, very high. So in terms of any calculation, any common sense, if you have 70% of the people who actually have the immunity, then it's only 30%. And if at any one time, the probability of those 30% going around in work or other sort of areas, the chance of them meeting an infected percent out of that 30% is going to be low. So that's how the herd immunity kicks off. So, and then by the time you get to 70% of the people infected, so you take a population of 50 million to, in some places, 150 million. And you look at that 70%, out of that 70%, by the time they get herd immunity, how many will end up in hospitals? How many will die? What will be the cost to the health economy? It's just, if you've done the calculation, sorry, yes. Sure.
Our rock star, Dr. Fauci, does not believe in herd immunity at all, because the very fact that if that was in place, we would have seen quite a few of manifestations and protections up until now. That's one. Two, he's also worried about 7 billion people across the planet to acquire this herd immunity, so-called herd immunity, if there was a hypothesis existing. But that is not in place, because by the time you actually have a herd immunity across the planet, there's a next mutant gene that's developing, and next you have a new strain. So I think that is just the myth in the whole thing, and we should not worry about that right now. First of all, we do not have a definitive therapy. Vaccines are still not approved. And I don't think the take-home message for the general practitioners or the people in the audience should be that herd immunity, we should wait out and blah, 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 and forget about the current resources, and we should be okay. That went around for a few months, even here in the United States, I should say. But I think the message from the top right now is there is nothing called herd immunity. Let's worry about what we are doing right now in terms of our resources and actually attacking the disease from the antiretroviral, from the antiviral and from the anti-inflammatory approach, and of course the supportive mechanisms.
Okay,
And most
thank you, sir.
importantly,
The
if you
next
look
question-
at the infections, various infections around so far in the history, there's not a single case of herd immunity to any of these infections through normal, population infection. There isn't one.
Okay. Thank you, sir.
Padma?
Anyway.
There is one more question. The doctor has mentioned we daily get calls that I was with positive COVID-19 case, and now what should I do to prevent the COVID-19 myself?
May I make the first attempt?
Yeah.
Okay. Well,
Yeah.
this is a classic scenario, man, as you said, and I think the question from the audience is extremely valid, because that's where we are. The premise of the infection is that we do not know who has COVID, who does not have COVID. Like I said earlier, you could be in the elevator going up to the 20th floor in Manhattan, and the next person who is sneezing could be having a common cold, or the person could actually be transmitting that in aerosolized fashion while you're taking that 2-minute ride or 3-minute ride. And even though you're protected, there's a good 5 to 6% chance that you may develop a COVID infection, number one. Number two, you're also looking at a protection. Now, at the protection level, yes, if you have been, because again, I'm coming back to Dr. Fauci again, and Dr. Fauci's recommendation is, or the thinking is going the following way: 15 minutes of exposure, not just an encounter of 5 seconds. The point I'm making is, if somebody just crosses like this, perhaps that's not enough to really get the infection. You have to have a 15-minute of interaction, either a close hugging or shake hands and what have you, and interaction. That will make the person more prone. Regardless, you still have to take the precautions, and of course, if you're still in doubt, go back and get your COVID testing done. But it won't be positive until at least for the first 4 to 5 days. Remember, you have to allow yourself have that incubation period, because you're still asymptomatic, assumedly, and as a result, first 5 to 7 days, you may be asymptomatic, but idea is not to go and get the test immediately after you suspect that, by the way, I was with a person just now. No, it's gonna be negative. That'll be a false negative test. So get the test in about 4 or 5 days, but until then, there's no answer. We don't have any answer.
Thank you. Thank you. Dr. Sancheti, that's about all.
Okay.
We need to
Dr. Arun Kant Sadbhai, he wants to ask something. Dr. Arun Kant, are you there?
No, sir. No, sir.
Okay, it's okay. Now, one more question. Has any definitive therapy really worked to show reduction in mortality yet? Any definitive therapy?
May I take that attempt?
Yeah, please.
Okay. Rajan, thank you. I know it's your dinner time almost, right? What we have seen is, as like I said in my earlier slides when I was presenting, remdesivir has shown to reduce the hospital stay, the MICU stay, by 4 or 5 days. So dropping from 15 to 11 days. No clear, well, I should say, actually in the first 28 days, the mortality has been shown to slightly improve, but first 28 days really doesn't count because you're spending about 2 weeks in the MICU anyway. So really what pans out is, even though there's only one FDA antiviral drug that has been approved, please do not use any other drug right now, they're saying. And anybody wants to sell or try to recommend, and any pharma wants to say, by the way, we have drug ABC, we should not use it unless and until it's FDA documented by ethical trials. Remdesivir is the only one that has been approved so far. As I said, only in severely or moderate to severely affected cases, or to prevent the progression of the disease. Like again, the president got the remdesivir for 5 days, but obviously one he's a high professional, and two, also it's a classic example where he was mild to moderately sick. So he was given remdesivir. So take that example in mind and use that very cautiously, please.
And
Hope it
last
answers
is
the query.
thank you, sir.
Sharad, just one more thing. In terms of reducing mortality, would you like to actually comment on the dexamethasone study of Oxford, which actually does reduce mortality if given at a particular time, which is, it's your area, your clinician, so.
Yeah, so again, dexamethasone has shown to decrease the progression. You're right, absolutely, just like remdesivir. But you do not use decadrone or dexamethasone right at the outset. You do not use that because that's where the inflammatory response, as we all are pathologists and microbiologists in our previous lives, we know that that's where the body's mechanism is working. So giving somebody a decadrone right at the first outset may not be helpful in a very severely ill patient who is coming with a higher inoculum, number one. Number two, if the inoculum is mild, maybe you can take that chance in giving decadrone on day 2 or day 3. But antiviral therapy has to be there first. You can use convalescent therapy and the monoclonal antibodies, as I said, because the antigens, once you demonstrate high levels of antigens, then. But the reading is the following, and the recommendation is the following. The way as I see it is, decadrone should be used only in the very severely ill hospitalized patients to prevent them going into MICU or shorten their MICU stay, or actually when all bets are off and all your hands are up, you say, look, I have nothing else to do. Unfortunately, and these patients are now so dismally ill, then you end up using decadrone as a life support. You're right. Hope that answers your question.
Last question I would take. What are the scenario in New York which are most applicable to work here also?
Oh, the scenarios, one of the things I'd like to say is, look, well, let's put it this way. I wanted to touch upon that, but quickly, let me because we are almost at the end of the session. You know, Governor Cuomo, our New York State governor, he just passed that law 2 days ago because these things are changing so rapidly. So essentially, what it looks like is the recommendation is the following: if you're coming from like the closest states, say for instance, New Jersey, New York, and Connecticut, they are like Haryana, UP, and Delhi. आप समझे? तो तीनों states जो हैं इतने पास हैं, उन तीनों में से तो सुबह शाम लोग आ रहे हैं, जा रहे हैं, तो उनके लिए उन्होंने अभी कोई order नहीं करने का कहा है. So the 3 states, the tri-state area, people are going back and forth. You don't need a documentation whether you're COVID positive or COVID negative. Now, what happens if a patient flies in from LA, the West Coast, and is now coming to New York? Now, that's a 5,000-mile trip. And now you're exposing that patient over here. So they are recommending that 3 days prior to the departure, within the 3 days prior to the departure, you have to document that you're COVID negative. 1, you arrive here, and then for 7 days, you self-quarantine. Get another test, and then if you're negative, you're free to move around the country. Get it? Although still following the hygienics. Now, if you decide to go back to California, I'm going very slowly. If you decide to go back to California, within 3 days of your departure from New York, you start to have that test, make sure it's negative, board the plane, and go back there and self-quarantine again for 7 days in California. Then you're free to move around the country there as well. So long story short, very simple, test 3 days prior to departure from point of origin, come to the point of arrival, quarantine for 7 days, get a test, free to move around, and vice versa, repeat the same. So this has now, because New York is extremely, because it was an epicenter only a few months ago, we cannot afford another second surge, and this rule is just passed only about a week ago. So thank you for bringing up that question, just to fill in that answer.
Dr. Sancheti, may I just give a brief comment on the mRNA vaccine?
Please, sir. Please, sir.
As I understand it, what essentially mRNA vaccine does is that it prompts the cell to manufacture and release a very COVID-shaped protein in sufficient quantities to provoke an immune response. That immune response preps the body to quickly recognize and attack any COVID-shaped proteins that are encountered in the body. What is not known at this particular stage is what impact that has on the capacity of the cell to produce mRNA for its own protein synthesis and process. So it is a very untested, it's a unique approach. Moderna has been involved in using it, and they're testing it along with Pfizer. So it's just important to understand that the mRNA is a new approach instead of looking at the antibody antigen type of a mechanism. That's all. Just wanted to share that with you.
I'm sorry, Rajan, I just now that you mention it, I just now didn't get the question right in the beginning. I had said messenger RNA, I would have understood. When I said, I was looking at this acronym mRNA, and I said, sorry, I haven't heard of it. Yes. So Dr. Inder Mohan is absolutely right on messenger RNA vaccine. Okay. So my apologies for not understanding the question early. But the key recommendation for a new vaccine for COVID-19, I have got a lot of these social media recommendations, and they say, reckon that it should be given to all the politicians first, and if it works, then give it to the population.
That is fine.
So Rajan, just to follow up on that, may I?
Please.
So your question was, how does it apply to the what is happening in the United States and New York? Can it apply to India? I think the infrastructure here is there. The fact is that it's also there. But here, as is, it's so difficult to really. Can you imagine a passenger boarding the plane and making sure that he is negative first within the 3 days, and that's required to be checked in New York at the airport, and then self-quarantine yourself? Can you imagine if all of that, with the vast population that you have in India, to execute that? I think that'll take a whole bit of logistics within, and the government and the private sectors, they have to be involved. But you're right. I mean, we are still learning every day on this, but it's a huge, huge concern.
Thanks a lot, sir. I hope all the take-home messages are, I would say, most acceptable from all of the delegates. Next, I would request our President, Madam, whether we should conclude for Thanksgiving.
Yeah. We can conclude. It's high time for the conclude.
Yes.
I'm ready for the high tea.
Yeah. We are ready for the dinner.
Oh, yeah.
It is 8 o'clock.
I'm actually ready. As a matter of coincidence, I have to go to my local hospital for my COVID-19 test. So I'm getting my first COVID-19 test today.
Okay.
All the best.
All the best.
It's only a pre-check for a place I'm going to. So they said you get it checked before we see.
I've heard that in the UK they have made it mandatory for everyone now.
Yeah.
With lockdown, yeah.
Thank you all the faculties. You are really stalwart, encouraging us, inspiring us, and I would say enlightening us on this COVID. Thanks a lot. And thank all of the doctors, delegate who have made this webinar a grand successful one. And lastly, I would thank Dr. Rajan Sharma, who gave us a big surprise to join, and he joined at the moment. So also Dr. Ashokan sir, Dr. Aminaj Bondwe, Dr. Ravi Wankhedkar sir, and all the faculties again. Thanks a lot, and we wish all the best. Lastly, I would say that Poonawala he's undergoing for vaccine trials, and hope India can be also a pioneer for having vaccines, and we are all geared up. If anything good happens, it will be I would say, global history. Now also today, it is I would say, history in Pune that all of you faculties have enlightened us for COVID-19. I hope all the delegates have appreciated. Thank you all the delegates. Thank you again, Dr. Aarti, our President. Madam, thank you again. I would thank all the faculty.
Thank you everybody for coming here and joining the webinar. Thank you.
Thank you so much for the opportunity that you gave.
Thank you very much for the opportunity.
We look forward to come around anytime whenever you wish to do
yes,
that.
Yes, definitely. We will do it again.
We'll continue.
Yeah.
We are having a series of, I would say, international webinar, as Dr. Peter said, and we would like also to have an opportunity to have a disaster management planning. Thank you again.